see.
สวัสดีค่ะยินดีต้อนรับทุกท่านนะคะเข้าสู่ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice ค่ะอาทิตย์นี้เป็นอาทิตย์ที่4แล้วนะคะซึ่งอาทิตย์นี้เราอยู่ในธีมของ CT นะคะแล้วเราจะมาพูดถึงในเรื่องของ CT ที่เราใช้กันเยอะมากเลยคือ CT ของ Body นะคะซึ่งก็คือทั้ง Chest Abdomen Pelvis นะคะว่าเราจะสามารถมีการ Optimization ในเรื่องของเทคนิคแล้วก็มีในเรื่องของ Dose Quality อะไรยังไงบ้างนะคะที่เราจะสามารถให้ได้ Image Quality ที่ดีสามารถ diagnosis ได้นะคะแล้วก็สามารถลด radiation dose ได้ด้วยนะคะซึ่งก็เช่นเคยนะคะเราก็ได้รับเกียรติจาก expert นะคะจาก IAEA นะคะดร. Sam Brady นะคะจาก Cincinnati Children's Hospital ที่จะมาเล่าให้เราฟังต่อนะคะว่าเขาจะต้องเราต้องทำอะไรยังไงบ้างแล้วก็เดี๋ยวมาเรียนรู้ร่วมกันนะคะ Good evening Sam we're gonna unmute you. Yeah. So good evening, Sam. Nice to meet you again. And I know this is very late. It's like at 10 p.m. in US time because of the daylight saving time. But thank you so much for continuing giving us a talk and teach us about the optimization in radiological practice. And so this is week 4 in the theme of the CT. We already talked about the DRL, how to establish the DRL, how to use it. And last week, we talked about CT of the neural part for head, mostly head, CT head. And this week, you're going to talk more about the CT abdomen, how to optimize imaging technique and reduce the radiation dose. So I give the stage to you to give a lecture. Mm-hmm.
Thank you very much. It's wonderful to be back with you. It is a little later for us here in the US. We have this crazy thing called daylight savings, but I am grateful to be here. So if I just fall over and fall asleep, I'll have Tanya just kind of text me and kick me or something.
Sure.
But anyway, so just like Tanya mentioned in the introduction, we've started down the path of CT. We've been talking about neuro last week. So today we're going to focus in on the body. But before we do, I actually made a promise. So there was right at the very end of our lecture series last week, we were discussing C-spines, which of course kind of sits right between the body and the head, and so but are always or almost always read by neuroradiologists and are typically grouped with with head protocols. And we were talking about having some reoccurring issues, mostly down in the C6, C7, T1, T2 area, and how when the C-spine is not properly optimized, you get this lack of conspicuity, you got lack of edge definition through the vertebral bodies. You get some pretty bad artifacting that obscures the cord. And so these are actually images from our scanner. And so this is something that I know a lot of people deal with. And so we talked about how we resolved this issue, but I wanted to give you some, there we go. I wanted to give you some more concrete examples of actually how to do this. So there was two main things that we did to help fix this problem. And so here, before I share with you how we fixed it, I'm going to share with you kind of what we were doing. So initially what would happen is our patients would be placed on the scanner, of course, and they'd have a scan localizer, would do an anterior, posterior, and then would do a lateral, which you see here. And from that, I am showing you obviously the lateral projection. And there are two plots that are overlaid this. They're a little hard to see. I know especially this yellow one that kind of disappears into the white of the shoulder. But this yellow line right here tells you how attenuating or how thick these locations in the body are. And so this is more attenuating as it goes down through the chin and enters into the neck. It's not that attenuating. Of course, there's not a lot of material, not a lot of tissue in our neck. But then, of course, as it enters into the shoulder region, that's where the attenuation goes really, really high. In fact, we all know this. Anyone that's worked with CT long enough knows that most of the artifacts we get in CT are going to be in the shoulder. And then, of course, there are some down in the pelvis and here at the base of the skull. These are just probably the three most attenuating areas of our body because of the bony structure and then just the physical size of our body. And so you can see as the system, when it measures the attenuation properties of the body using this localizer, it calculates how much radiation output it would need for the system to penetrate and create an image and reconstruct an image. And so initially, as it's passing through the face, the overall head, and even through the neck, it's pretty much nothing. It's zero. Well, not zero, but it's hitting the minimum MA that we have allowed the system to go. In fact, you can see here, I just wrote out a couple of them based on the actual physical location in this sagittal projection of the C-spine. So as it's going down through C1, C2, 3, 4, it's basically just hitting the minimum MA. But at that point, it needs to start to ramp up to get through the shoulder. And so it doubles here and it quadruples by the time it gets through the shoulder. But you can see, even though it's doubling and quadrupling, it's not quite enough output, not enough radiation for the system to faithfully reconstruct the anatomy here. And so that's why you're getting all this artifacting. So there's two things that we did to fix this. The first thing was we simply turned the machine around. We said, okay, well, we're going to start scanning from the shoulders and we're going to go towards the head. So instead of cranial-caudal, we're going to go caudal-cranial. You can see the attenuation profile in this patient slightly different. It's a different patient, of course, but the attenuation property is basically the same. The shoulder, obviously really highly attenuating as it goes through the neck. It's not so much, and then through the head. And where impossible, you can see this patient's a little bit more positioned. The neck is not so, the chin isn't so close to the neck. So it helps kind of stretch out the anatomy. Now I know C-spines, the patients might be getting a C-spine and the neck may be compromised. So you may be just limited with what you can do to position the patient. But in this case, this patient's pretty well positioned. And by turning it around and going this way, now the system starts at the highest dose. In fact, you see this red line is actually the output. And the fact the system turns on and it realizes, hey, I need a lot of radiation, and it pushes it all the way through. And so you can actually see as it went from basically the T2 level up through the base of the skull, the dose actually in this case was the same. And the reason for that was we increased our minimum MA limit. So two things we did. We started the position to go up, and then in this case, because it's a Canon scanner, just like GE, you have to set a minimum and a maximum MA. In our previous one, we had, as you may recall, 25. It's a smaller patient, but nonetheless, our minimum MA was, a quarter of what we were doing now. And so we realized when we looked at our data, our image quality and our dose, it was just too low. And so we actually increased our minimum MA. And by increasing, you can see here, the system still used the minimum because it didn't feel like it needed more, but you can already see the improvement in the bony structure of the vertebral body. Everything seems just so much better than it was previously. In this case, this patient was even thicker through the shoulders. And so, excuse me, once again, starting from the caudal and going cranial, you see the attenuation profile is actually a very steep attenuation profile through the shoulders. And so the MA actually started much higher, here about 240, but it was able to, as it left the shoulders and entered into the neck and the head region, it was able to ramp down very quickly. And so, in fact, you see the steepness of this plot right here compared to, and I'm going to go back 2 slides, this is not as steep. And what we found was the system didn't ramp up the MA as fast as it could ramp down the MA. So it could go from 240 to 150 back down to its minimum very quickly. This is a thicker patient, and so the bony nature was still, the vertebral body was still very well visualized. There was maybe a little more translucence in nature in it, but still artifact-wise, it's much, much better than it had been. And so all right, sorry, those slides are out of order. So just quickly in summary for our C-spines, the two main things we did and that we talked about last week was we increased our minimum MA. So you just need to make sure you're actually using enough radiation. Too often we talk about reduce MA, reduce dose. We want to get as little as we can, but there is too low. That does exist. In pediatrics, which we are a pediatric hospital, too often people have talked about reducing the dose so low, but it actually makes it so that it can be at times very difficult for our radiologists to do their job. So we established a new minimum MA, and then by switching the angle and starting from the bottom and scanning up, it allowed the system to have a much more appropriate ramping time, and so the MA could match. And so we actually compared our profiles, our dose profiles, with several others. We get a lot of referral imaging, so we're able to compare with other hospitals around the nation. And after I normalized it here, you can see, so our doses are still lower than others in the US, but because we established, you can see here the angles, this gradient here is less steep than it is here. But now once we fixed it, the angles or the gradients were the same angle. So that was probably one of the biggest things to fix the issue. So anyway, I just wanted to give you some pictures of and give you actually some data, because we did physically talk about it, but we just didn't actually have any data to talk to you, to show you. So now switching back to actually the topic for today, which is body CT. So we're going to talk the trunk, chest, abdomen, pelvis. And so I showed you the very first neuro image ever acquired on a CT. It was back in, I think, 77, last week. And here I'm showing you the very first chest and the very first abdomen image. Now, these are clinical. They, of course, had done a lot of CT imaging on volunteers and on dogs and animals, but this was the first clinical system. That right there is Dr. Hounsfield, Godfrey Hounsfield. He is the one that essentially invented the CT scanner, and that's why we call our CT numbers Hounsfield units. It's named after him. And this gentleman, I'm drawing a blank on his name, he's a radiologist. He helped develop the clinical utility for the CT, and Hounsfield was the physicist, and obviously he developed the engineering side of it. But the point here is, look at those images. We have come a long way. And I made this comment last week, and I hope that you appreciate it even here looking at these images. The advancement of technology in CT will do more to change or improve the image quality and the dose reduction ability than really all of the small little knobs that we can twist. And so when you are fundamentally working with a CT scanner that's 10 years old or 15 years old, you're just going to be limited with how much image quality you can improve and how much dose you can reduce. It's fundamental because of the age of the technology. But as we go forward, about every 5 years, CT technology makes a really big step forward. And so I'm not saying that we always need to buy a new scanner every 5 years, but I'm just saying that as we try to stay on the front of that technology wave, we have the ability to really harness a lot of the good image quality we have now in the low doses. And I showed you a lot of those pie charts last week about how, at least in the US, most of our doses in over a 10-year span have come down, even though utilization for the CT scans for the chest head, all aspects of the body have gone up. And that's just mostly because of technology has been improved and we have been able to harness that technology. All right, so last week I demonstrated this interconnection figure. It's a web that basically takes the higher level goals of image quality, or really of just radiology in general. This idea that we need to establish the proper utility or appropriateness of the scans, and then how we establish that utility, we can then go all the way down to the left side of this plot, and you can see this long list of items that we need to optimize. We have obviously talked about, we've split up the two talks today. We're going to start with image quality, and then later we'll talk about dose. But you can see that image quality is only a small subsection of the optimization program. And obviously radiation dose is another one, actually an even smaller subsection, radiation dose being right here. So we went over the idea that we needed to optimize all of these values here. These are all the values that are directly connected to image quality. And so we did that for the head. So we're going to do that again today for the body. But I wanted to start off by asking this question. Excuse me. This list right here of, scan mode, KV, tube voltage, pitch, spatial resolution, you see down here, noise, all of these things that we talk about optimizing, how constant are they? If we were to measure them every day for a couple of years, would those values be consistent in time, or would they drift? So this is a question I asked a couple of years ago. And so what I did was every morning, our CT technologists, much like I assume your CT technologists do, is they place a phantom on the scanner. And part of the warm-up process and the calibration process is they scan that phantom. Now, I'm not 100% certain exactly what you all require your technologists to do. But one of the things that I developed, at least at our hospital, was I have them scan the phantom, and then, I ask them to make sure to look at it, just visually look at it, make sure there's no artifacts, there's no rings, there's no streaks, just it looks like a good quality image. And that gives them confidence that they know when they put the first patient on for the morning that the scan's going to look good. And then they send this image to me. It goes off to PACS, and PACS sends it to my computer. And I then I wrote some code that does a lot of analysis on it. And so what you're seeing here in just this plot specifically, you can see the days of this was last year, 2020. And so we used our CT scanner basically 340 something days. And every day they sent me this image, I was able to make a few measurements. And so here I measured the various different CT numbers for all the sensitometry, lung, water, IV enhanced or bone, soft tissue, kind of like muscle. And I wanted to see how constant they are. So I'm only showing you two things here. First, I'm showing you noise. And so this is the standard deviation of this yellow ROI. And so when you use the same water phantom every day, the system was consistently creating or calculating the same amount of noise. In other words, that when you dial in an MA or a KV, the system was very consistent in actually using that MA and KV to create this image, and therefore the noise was constant. The other thing was how consistent was the CT number. And water, as you all know, should be zero. Mathematically, it should be zero, but it's not always perfectly zero. So we allow it to be somewhere between plus or minus 3 or plus or minus 5 CT Hounsfield units. In this case, it's basically 1 consistently. And it kind of ran into this little blip right here for a couple of weeks back towards the end of last year. We had some issues with our CT scanner, but we worked them out, and you can see they all got back on track. So when the system is functioning properly, which you would expect it to, you can see the CT number is consistent. Now, we also talked about noise power spectrum in our first week, which gives you an estimate of the total noise variance in the image and the texture of the noise. Is it going to be coarse and blobby, or is it going to be sandy, really fine? And so here I'm measuring the noise power spectrum in various different areas in the water. And that's what you can see here. The color of the plots correspond to the color of the ROIs over here. It doesn't really matter where I measured it, but basically I'm looking at the peak of this value. And looking at this peak, so you can see here, the red one dead center, it's somewhere just shy of 0.2 cycles per centimeter. And so you can see here over the course of the year, it varied a little bit between 0.15 and 0.2. In other words, the noise texture was consistent every day of the year, and the overall variance was pretty consistent. And then similarly, we wanted to know about the spatial resolution. Day in and day out, would the edges of the objects in our body, the bones, the maybe tubing lines, whatever it is that has really strong edges, the edges, the capsules of our organs, all of these things, how consistently resolved or sharp would they be? And so that's what the modulation transfer function or the task transfer function calculates. And so here I just arbitrarily looked at the 50th percentile. So this value right here, if you draw a line over and you draw it down, it's somewhere in the 0.3 range, which is what you see here. And once again, there's a little bit of variability, and obviously the system kind of had some hard times there, but it got back onto track. But you can see that it's fairly consistent day in and day out. In other words, it's something that we would expect that our CT scanners would give us the same resolution every day. And then finally, the question really is, we've always talked about how we can calculate contrast to noise ratio, MTF, NPS. We can do all these really cool physics calculations, but what does that mean to the radiologist? Does their detection task change? And so here we talked about this idea of being able to have this detectability index, understanding exactly or predicting how well an individual like a radiologist is at a specific task. In this specific task, I am calculating their ability to look for soft tissue lesions and what is the minimum lesion size that they can see for at all different contrast levels and different tissue types. And in this case, when I put all the data from the previous 2 slides or 3 slides into it, the TTF, the NPS, all that, you can see it basically calculated kind of that minimum of 4 millimeters for everything. Now, obviously, at a little less, and this is perfect sensitivity. In other words, at all times, basically, radiologists would never have a problem finding a 4 millimeter object. And that's probably true anyway. But as they get smaller and smaller, obviously their sensitivity drops off to the point where it's 0.5, and 0.5 is a 50-50 guess. In other words, once it hits the x-axis down here, that's basically saying the radiologist is no better at guessing than they are. One radiologist can guess, and it's no better than the next radiologist guessing. Anyway, so the point here is even though we did see some variability in some of our measurements, because the system did have some troubles, you see in that same region, the sensitivity, the doctor sensitivity was predicted to be the same. And so I guess the take-home message for all of this is the fact that these scanners are very robust. And so once we've optimized them and we've tuned them, the system will actually perform pretty consistently over time. And like I mentioned, I've been doing this for about 1.5 years, 2 years now, and the data is just constant. And so it should give us a lot of confidence that the effort we put into optimizing means that those protocols will then continue to go forward as long as we, obviously use the system properly. So just as a quick reminder, when we talk about optimization, this isn't one person, this isn't a physicist, this isn't the radiologist, this is a team, radiologist, technologist, physicist. And then as we talked about last week, having someone like from IT, computer savvy, that's able to help us make sure all the images are leaving the scanner and getting to PACS and getting from PACS over to the reading station, and everything gets where it needs to be. Every one of these people here, the individuals highlighted, they all have a very specific specialty that they are experts in. Radiologists obviously have the expertise in what they need to see. The technologists have the expertise in how to operate the system and to perform the task. The physicist has the expertise in the fundamentals of creating a system that can actually create those images. And of course, the PACS person helps the IT folks get the images where they need to. So in every respect, when we go through all of these slides, we have to think of how each one of these tasks is something that as a team we can approach. So here's a CT scanner stripped down without its covers. And when we talk about areas of optimization, we have that one long profile with all of the long list of things. Today, I thought I would just kind of strip it back a little bit and say, let's look at the major components of the CT scanner, especially for the body, and how do they affect image quality and patient dose. So we're going to talk physically about the actual generator, which is the thing that produces the energy to create the radiation. Obviously, the X-ray tube here connected to the generator, it obviously creates the X-rays as the energy comes from the generator into the tube. The tube creates the X-rays through Bremsstrahlung radiation, and they come out and they go through a filter. We call it a bow tie filter. And then, of course, eventually they pass through the patient, where there would be a table here, and then it goes down to the detectors. And so the gantry holds this whole thing together. So when you can, and then of course we need the reconstruction software on the side that actually takes all that data and creates an image. So when we consider the head CT, which we talked about last week, most of us have the same size head. When you become an adult, as a function of age, even kids, basically as they continue to grow, we all basically have the same size head. And it's all basically made of the same material. We got skin, a little bit of muscle, and a whole lot of bone in there. And so therefore, when it comes to optimization, we're typically using, when you consider this, we're typically using about the same output. We're using the same filter. We're usually using the same, although there was discussion of using a wide beam width, so a wide detector coverage versus a short. We talked a little bit about the reasons for those. But for the most part, the head didn't really truly require an optimization of all of these components. But in the body, of course, as a function of age, we are so much different. And even when we're all the same age, we can be quite a bit different in body habitus. And so there's a higher degree of variability and therefore a greater need for optimization in the body. We use all kinds of different KVs and all kinds of different outputs. We use all different kinds of filters, and the detector needs to be optimized differently for slice thickness, for coverage, etc. So when we talk about optimization, let's kind of start back up at the top of the machine. The photons, the x-rays are coming out of the tube, and the very first thing they're going to do is they're going to pass through this filter. We call it a bow tie filter. Kind of looks like, you know, a typical bow tie that a gentleman might wear. And the reason we have the specific shape of this filter instead of it being just a flat filter is we are typically oval in nature. We have an elliptical a very generically elliptical shape, especially in the body, because we're talking body. And therefore, the photons that come directly out and straight out, down, and perpendicular from the tube, they're going to basically pass through probably some of the thickest material of our body. But yet those that are coming off on an angle will have very little material to pass through because they'll be going through at an angle at the edges of our body. And so what we need to do is we need to equalize the photons as they come out. So we understand this. You guys have all learned this in your schooling. And so the bow tie filter is basically the inverse shape of our body. It's more attenuating on the edges and less attenuating in the middle, as we are less attenuating on the edges and more attenuating in the middle. The net result is that when the photons come through the bow tie filter and pass through our body, they will strike the detector and the intensity will mostly be the same, assuming if this was like pure water. Obviously, there's slightly different if there's lungs and bones, but the idea is the spectrum is consistently the same. And so we equalize through the body, equalize through the periphery, and basically it helps us to maintain a good starting point. This is the most fundamental place to create a good image, is getting the right size filter, using the right size filter to create the image. Now, every system, every vendor has multiple choices and multiple options. Here is an example of one of our Canon machines. It's got, as you can see here, 5 options going from large or double large or extra large to extra small. And so you can see these bow tie filters from a collimator. In this case, there's only 3. And so the technologist will have the opportunity to change this if they need to, because of the size of the patient, and that will help optimize the overall image quality by getting the right size filter for the right size patient. Now, the filter does more than just simply equalize the photons coming out. It also removes low energy radiation. Low energy radiation does nothing to contribute to image quality. All it is absorbed superficially in our body, maybe at the skin and the dermis level, which basically means radiation dose to the body, no benefit for image quality. And so having these rather thick bow tie filters allows us to actually reduce a lot of the unnecessary radiation dose to the body. But what that does, as you may recall from your days studying physics as a technologist or radiologist, is that when the photons pass through a filter, it absorbs all the low energies and only the higher energies or the more penetrating photons survive. And that means those have a higher, what's called half value layer. And so they're more penetrating. And the net benefit from that, and I hope you can see this difference, is the lung tissue here is a little bit more black and the soft tissue is a little bit more, I would argue that there is more of a differential in the two contrasts here compared to the image here on the right, which it's a good image. You can still see the lung parenchyma, etc. But the intensity, the difference of the blacks and the whites is not as strong. And that is simply because as we have a higher or larger half value layer or more penetrative, a photon that has more penetrating ability, you get more distinctive contrast differential. You know, fats and soft tissues in the lung, and obviously soft tissue and bone. So because of the unique nature of the bow tie filter, the most critical component of the day when you put the patient on the machine is getting that patient centered. When it comes down to it, dose and image quality are directly linked to where that person is within the bore. If they're off-centered, obviously here left to right, or if they're off-centered up to down, it will directly affect the dose, which we'll talk about in our next talk, and image quality, which we're going to talk about right now. So first of all, how does an off-centered patient directly affect our image quality? Well, here's an example. The center column represents an individual, in this case a phantom, that is well centered. And then you have on the left side a patient or phantom that is too superficially high, so it's closer to the x-ray tube. And then in this case, where the x-ray tube would be up here, in this case with the x-ray tube up here, the patient is too low. So you can see here centered, overall the image quality is generally okay. But when you get off-centered, especially lower in the gantry, you get a lot of the streaking, the beam starvation, and you can kind of see some of this beam hardening artifact, this kind of darker blackish or dark gray areas, basically loss of signal. So the patients lower in the gantry lead to more artifacts. You may argue there's a few artifacts in this compared to the center one, but off-center leads to greater artifacts. Now, we'll talk quite a bit about the dose on the next talk, but rest assured, those two, that patient being off-centered is directly going to affect the overall quality of the image. And so, like I said, the first thing when we're talking optimization, it doesn't always have to be a knob we turn. In this case, one of the great things we could do as an optimization team is we could make sure, we could work with our technologists, that our patients are always centered. The radiologists, obviously, when they get the images as they come across to the reading room, they'll be able to see if the patient is down, or they'll see the net effect of increased artifacts. And then also physicists and other quality assurance individuals, as you guys get radiometrics and other tools, a lot of those will be able to calculate to see if the patient is too low. And so there are ways where we can optimize this by tracking and verifying that we're getting the patient centered. All right, so moving on. So what is so there's basically the two parameters. We have the patient on the table, the patient's nice and centered. And when the technologist sits down at the console, one of the basically two things that have been selected for them when they pull up the protocol is the KV and the MA. And we're going to talk about MA in a minute. So let's talk about KV. The two potential, that is one of the fundamental things that are already set. So that's usually something the technologists don't change, which I'm not 100% certain how they do it in Thailand, but I can vouch for what I see here in the US is those are all predetermined in the protocols that are built by the optimization team. Most scanners nowadays have a very wide range of KVs. Historically, we've always had 80, 100, 120, and somewhere around 140. Some do 135, most do 140. Nowadays, with the enhancement in these X-ray tube and generators, we actually have opportunities to image at a wide variety of KVs, going from 70 up to 150. And we'll talk a little bit about why we'll use maybe 150 and 70 more next week when we talk dual energy. But for the most part now, we'll just focus on the standard 80, 100, 120, and 140. All right, so how does KV change the quality of the image? In this, I had a very basic, it's a water-based phantom, and it has these sensitometry rods in it. And so each one of these little inserts basically mimics a different tissue in our body. Obviously, you got bony anatomy, maybe contrast infused, vascularity, some lungs, air, soft tissue, maybe muscle. So it's all meant to be just kind of a way to calculate, to see if the system can calculate the correct CT number for all of our various different tissue types. Here you can see I've selected three of them, 3 sensitometry rods, and I put a blue, a green, and a red box around them. And you will see that they correspond to these 3 plots in the same colors. And I scanned or imaged this phantom at different KVs, going from 140, 120, 100, 80, and 70. I kept the MA, or the radiation output, the same or constant across all of these images. So there's a couple of things we can see. As we shift from high kV to low kV, the overall quality of the image or the noise content decreases. So you go, if you're not changing the MA, you're just simply changing the kV, the images get noisier. And you may argue that the texture does change slightly. You go from a kind of more of a finer noise to a more coarser noise. Okay, but we can handle that. We'll deal with that in a moment. But the other thing that changes is the actual value itself. So the CT number, as you go from high kV to low kV, the CT numbers do change. And so the only material that does not change is water. And this was basically, it's actually not a true water. It's actually a plastic-based water. And that's why you can see here, it actually changes just slightly. But for the most part, it's pretty much close to zero. And so we'll call that not changing. And then, of course, fat changes and the bone changes. And so when we set the kV, we have to set two things. We need to set the right MA to accompany it so we don't have this crazy enhancement of noise. And then we also have to recognize the fact that the overall intensity of the image is going to change as we change kV. So what do I mean by that? Low kV imaging leads to better tissue contrast differentiation. So the lower the kV, what's causing this is we're getting more photoelectric absorption in the body. You know, you may recall from your school days, photoelectric, Compton, pair production, all of those fun interactions, radiation interactions with tissue. Well, photoelectric effects happen at low energies and high atomic numbers. And so you can imagine anything with a high atomic number, such as IV and iodinated contrast or bony anatomy, how they're going to absorb more photons. And so they're going to have an inherently greater differentiation in tissue. So we will see a more intense differentiation between IV, iodinated contrast, and bony material from all other material in the body. And you can see here, we have an iodine contrast injected into this patient, imaged at 120. In the liver, the vasculature is, you can still see it, it's definitely differentiated, but at the exact same patient, but now imaged at 80 kV, the iodine in the blood it pops. It's way more intense. And that's because of this lifting from 140 to 80. You can see you've doubled the CT number. In other words, you've doubled the intensity of the signal. And then there's obviously just an overall differentiation from the water-based materials, the kind of the soft tissues that do not infuse with iodine. So here you can see muscles, maybe even some of the fats, but mostly muscle to soft tissue that is iodine, that has iodine infusion in it. You can see there's more differentiation. And so these are the two main regions, obviously why we inject IV, especially in the body, is so we can kind of see the vasculature and we can kind of start to differentiate the different tissue types. But it is much more intense and much more apparent at lower kV. So we can look at reducing the kV and doing one of two things. So if we take where our protocols that are typically in the body imaged at 120 kV, but now we move towards a, say, 100 or even an 80 kV value, one of the things we're going to do is we're going to improve the overall contrast to noise ratio. As you remember from the previous slide, it was just greater contrast. And we gain the ability for the same contrast to noise ratio and the same radiation dose level. We either improve the CNR, so we do decrease 120 to 100, and this curve goes up. Therefore, we get more intensity in the image. Or we can reduce the amount or the we can reduce the amount of IV oral contrast dose. And so we can go from, say, as an example, 10 milligrams per cc, which is what I used in this study, down to 2 milligrams per cc. And so by changing from 120 kV to 80 kV, the contrast per dose stayed the same. In other words, using a more diluted version of iodine, the image would still be the same intensity. It's just we've actually injected a little less iodine into the patient. So once again, to recap, you can either improve the intensity of it, just totally increase the intensity of the image, or we can actually try to mitigate a different kind of risk. We're not talking dose risk. We're talking we're talking an iodine dose risk. And so maybe someone has compromised kidneys, or we're talking a very young patient and we don't want to overburden or overload their system. Maybe you're doing a CTA. And so those tend to have a higher concentration and a higher overall dosing of iodine. But we could, if we just simply optimized our protocols at a lower kV, we could reduce some of that burden. Now, the only comment I make for that is this is mostly an effect that we can see in pediatrics. When you get up to adults, you can see these curves don't quite cross anymore. And so if I go from in this case, I was up to 135, but if I go up from 120 kV down to 80 kV, this curve never intersects with the 100, or it never intersects with any of the lower concentrations of iodine. In other words, to keep the same contrast to noise ratio per dose, I would actually have to increase my dose to actually make this work. And so this idea of diluting your contrast at lower kVs doesn't really make a lot of sense in adults. But for kids, which is probably the more risk, it's probably more sensitive population, it's something that you could consider if you were interested in. All right. So how do we know which kV to select? Well, you can go through and you can manually set the kV for every one of your protocols, which is kind of like, that is typically how we've done that for many, many years. But over the last probably about 5 or maybe even 6 or 7 years, most of the vendors, the CT vendors, have come out with a new technology that does auto kV selection. Now they call it all something different, kV assist, auto kV, etc. But the point here is, the point here is that the patient gets put on the scanner, and then what we're doing is we'll do a CT localizer scan, and the system will be able to measure the patient's thickness. And at the same time, the technologist will simply tell the scanner, okay, this is going to be either a non-contrast image, a contrast enhanced image, a soft tissue goal, we want to look at for soft tissue, or this is something where we're looking at bony anatomy only, like MSK type stuff, or we're looking for implants. And so the technologists would tell the system generically kind of what's the overall goal of the imaging. And then from that, the system will then pick the right kV to maximize the contrast to noise ratio. And this is done because in the background, there's a bunch of curves and stuff built into the scanner. And so the system already basically knows, as a function of patient size and a function of task, it knows which kV to select to optimize contrast to noise ratio. So there's a couple of comments about this. First of all, you absolutely need to build constraints into the system. When we got this system years ago and we looked at it, the first thing we knew was we did not want, for our little kids, the system to ever pick a higher kV. It's okay if it picked a lower kV, but never pick a higher. As you remember, when we went from 120 to 80 a couple slides ago, the contrast enhanced, and that's a good thing. Now, if the converse happens, you go from 120 higher, 135, 140, 150, the contrast will become more diminished. And so in this case, we never really wanted the system to go higher, even if it was a big patient. So that's a decision you have to make. But in our case, we just never wanted to use those high values. Now, once the KV is selected, you need to understand that it will use that same KV for the entire rest of the series. We will talk a little later in the next talk about tube current modulation. And so this is not tube current modulation. Tube current modulation changes the MA as the tube spins around the body. KV will, once the system picks a KV, let's say it picks 100 kV, that means from top to bottom, every series thereafter, they will always be imaged at 100 kV. So, is this beneficial? There was a study that was done in Boston, which is a state here in the US. And what they did at this hospital is they looked at 86 studies. And they basically compared them, they kind of broke them down based on the patient weight versus the protocol. And they said, okay, if this patient was 60 kilos, this patient was going to be imaged at 120 kV. If this patient was 40 kilos, this patient was going to be imaged at 100 kV. It's written into the protocol. That's just what it would what would happen if they used the protocol on the system. And then what they did is when they put the patient on the machine, they let the machine pick the KV. And so they compared it to what it would have been to what did happen. And what they found was that in 31 cases, a particular auto KV selection option, this is Care KV, it's a Siemens system. So it's the same, it'll be the same result for GE, Canon, and Siemens, but I'm just saying they used a Siemens system. So in 31 cases, their Care KV selected the same KV as had been written into the protocol. So in other words, there were no differences. But in 49 cases, the Care KV selected a lower KV. So the take-home message was, in general, we could probably image more often at a lower KV without any change to our image quality. Well, actually, it'd be an improvement of our image quality, but it wouldn't be a negative. We can go lower without having any issue. So if you use auto KV, that would help you get there. If you don't have that technology or you're not comfortable with that technology, then just consider the fact as an optimization team, you could go back and take a hard look at maybe your chest, abdomen, or pelvis protocols and say, you know, if we're routinely doing everything at 120 kV, is there an actual population within our, subpopulation in our patient group that could actually be imaged at a lower KV, such as smaller patients, thinner patients, patients that, for example, are going to get a CTA or kind of a contrast enhanced image. So what are some caveats to KV? The first is focal spot. You have to think about the actual size of the focal spot, which affects the spatial resolution in the image. If you want high resolution, fine structure imaging, you want to use the smallest focal spot available on the CT scanner. Almost all CT scanners limit the amount of MA that can be used for the small focal spot. Now, as you can imagine, if you have a really teeny small focal spot, so all of the radiation is being focused on a teeny little location on the X-ray tube target, that means a lot of heat is going to be at a very small area. So you can't just turn up the MA super high, you'll physically burn a hole in your X-ray tube. So most places will limit it roughly around 350 MA. Therefore, if the system needs more than 350 MA to create the image, the system will automatically change from a small focal spot to a large or an extra large. So why does that mean anything for KV? Well, we will talk about this more specifically in the next talk, but because we go down in KV, we typically need more MA to create a cleaner looking image. Remember, my image in my slide where I had five phantoms, and as I progressed from 140 down to 70 MA, once I got to the 70 MA, that image was really noisy, wasn't it? For a fixed MA. Therefore, as I decrease KV, I actually have to increase my MA. And if I'm constantly increasing my MA as I go lower and lower in KV, there's going to come a point where you're going to need more MA than 350. Therefore, lower KV imaging, especially when we're doing it in adults, because we can do a fair amount of 90 and 100 kV imaging in adults, almost always requires more than 350 MA. Therefore, you will be using a larger focal spot. It's a small price to pay, but know that if you need really fine imaging, so we're talking about maybe we're imaging a neonate or a little baby, or maybe we're doing MSK stuff where we're really looking at for fine hairline fractures in our bones. Well, in that case, you really want to make sure the MA never goes over 350. And so in that case, potentially, you keep the KV at 120. And therefore, the system would not need that higher MA. All right. Now, the other thing you have to optimize is the actual appearance of the image to our radiologists. So you have gone in, you've dialed your KV down. Now you're routinely imaging, let's say at 100 KV or maybe even lower. You maybe even were able to reduce the contrast and concentration, the iodine concentration. I mean, you figured out all these optimizations that you've done. But when you actually acquire it at a lower KV, because of the intensity of the CT numbers, because they are different at lower KVs and higher KVs, the images will look different to the radiologist. So if you use the same soft tissue window width and window level, remember what a window width is basically just telling you how many grayscales will be used to create that image on the monitor at any given time. And the window level value is simply you telling the system which tissues to focus on. So in this case, if we set a window level at 40, it's going to be kind of down here in the soft tissue, water, fat region. So it's going to really demonstrate good, strong detail in those tissues. But everything up here or down up here in the 1,000+ range for bone, and everything down here in that -1,000 something air, you will not be able to see any detail because it'll just be washed out, which is very true here, right? You can see the liver, the spleen, the kidneys, they're white light bulbs. So what happens here is you need to actually change your predefined window widths and window levels. So the first image that appears to a radiologist doesn't look like the one on the left, but it looks like the one on the right. So it's just one more value. And this is where the PACS IT person might need to help set that up. So the hanging protocols that the radiologists are so used to looking at, once you've changed your KV from 120 down to say 80 KV, now it appears and you can see a greater level of detail for all the soft tissue and the bony and iodinated contrast enhanced tissue. Okay, so we've talked about the patient on the machine. We've talked about KV as a button to change. The other one is how fast the X-ray tube will rotate or spin around the patient. All of our more modern scanners can go a minimum of 0.5 seconds. That's pretty much the minimum for even the older technology. But a lot of the newer ones can go 0.35, 0.275, 0.25. Some may even get down to 0.2 within the next year or so. That's pretty darn fast. And we talked about in head how we want to go as fast as we can. It's the same thing for the body. It is the same thing for the body. So here, it's probably even more critical in the body. In the head, yeah, there are some pulsatile issues with blood pulsing through the vessels. And obviously, the patient can have gross motion artifact by moving their head. But in the body, especially the thorax, there is involuntary motion that it's just we can't prevent. You can't tell you can tell the patient to take a deep breath, but you can't tell them to stop their heart for a moment. And so there is always going to be motion in this region. And so here's just one example of one of our patients where we acquired the images at a 1/2 second rotation, which is pretty darn fast. But you can see this vessel right here. It's got the telltale sign of motion artifact. We call that the railroad track artifact. or the track artifact. And here we imaged a different patient at 0.275, so a little faster. And here you can visualize this vessel. Very good and clean. And so what is this? This is simply freezing motion by imaging faster. So by doing volume mode, remember we talked about there are two vendors out there that sell scanners that can do 160 millimeters or 16 centimeter wide in a single rotation, which is pretty good. You know, generally speaking, that will cover the entire adult heart in one single rotation. Can't get much faster than that. But there are other machines that do helical imaging. Excuse me. And that, so the table is moving fast and the machine, the x-ray tube is moving fast. The two of them are moving really fast. And so we can get the patient through pretty quick too in these high helical modes. So better motion control equals better dose control. How is that? Well, that's just because we're not repeating our patient scans. And then this is just a quick reminder. Historically, most scanners operated around 4 centimeters or 40 millimeters. In fact, even some of our most advanced scanners that can do 160 are still actually operated at 40. Now, there's reasons for that, and I'm not going to get into all the detail. But wherein possible, if you can do a single rotation, say you're imaging the heart, or maybe you're doing just a more specific look at the kidneys, or if you have a little one, like a little neonate or a baby, oftentimes we can image a chest, an abdomen, or a pelvis all in one single rotation if we use this 160 millimeter option. So if we're not going to do volume mode, we're going to use helical mode, or not axial mode, we're going to do helical mode. And so to helical mode, as you all remember from your days in school, basically what's taking into account how fast the table is moving. This table feed per rotation, and it's divided by the overall total collimation, the number of detector elements and how physically small they are. So most of them are 0.5, one vendor has 0.625, and then they all come in a variety of and a number of different configurations. So let's take a couple of examples here. If the value is a pitch less than 1, then the x-ray tube is actually spinning faster than the table is moving. And so all parts of the body are partially scanned more than once. So here you can see the distance traveled by one couch during one rotation is 10 centimeters, but the width of the slice is, oh, that's a typo, 5 centimeters. And this is a actual total slice of 10 centimeters. So 5 divided by 10 is 0.5 or less than 1. And so this is great because it'll give you really good detail of the body. In fact, almost every one of our protocols are imaged at pitches less than 0.1, less than 1. Now, does that mean the doses are higher? I'll answer that in my next talk. Now, if the system has a pitch of 1, that means the distance traveled by the couch during one single rotation is going to be the exact same as the overall total collimation that you've established. So here is an example, 10 centimeters divided by 10, you get a pitch of 1. And then, of course, if the pitch is greater than 1, that means the tube spins slower than the table pushes through. And therefore, there are actual parts of the body that are not directly exposed to the x-rays. So we will answer the dose question in the next talk. What does change when we go from axial or volume mode to helical? Well, obviously, time. So pitches of, if you dial a pitch greater than 1, the scan will be done faster. If you do a pitch less than 1, the scan will, by nature, go slower. Is image quality affected? It can be. There can be more artifacts from high pitch helical imaging. This is an interpolation artifact. If you're doing anything over a pitch of 1, well, there are parts of the body that are not directly scanned, but we still need to reconstruct those. Our radiologists don't want big gaps in their images. And so what we do is we will take a little bit of data from one slice of a scan and a little bit of data from another, and we'll combine it and average it. And that's how we create these slices in between that don't have a lot of data or are missing some data. And because of these interpolation artifacts, especially for really high pitch values, you can get what we call windmill artifacts. Now, these windmill artifacts are typically found usually at the bone air interfaces or where there's like a wire or a tube that's been inserted into the body. But to know that this right here is a direct effect of using a pitch of greater than 1. Now, as I mentioned, if we go less than 1, is there a change in image quality? And the answer is yes. Well, it may lead to improved image quality. It's usually typically, we use this because it oversamples the tissue and it really gives us good fine detail, not only in the transaxial view, but actually it makes the biggest difference when you're looking at your reformats, your sagittals and your coronals. So pitch less than 1 is actually oftentimes used. And as I mentioned, I'll tell you how it affects dose. Now, globally, helical imaging will always introduce a slight amount of blur in the image. So obviously here in the lungs, yeah, there's potential blur just because they may not hold their breath or the heart is moving, right? But if you actually look at the texture of the lung in this pretty good breath hold compared to the texture over here, excuse me, and even look at the edges of the muscle and soft tissue and fat boundaries, they're stronger or sharper in the axial. And that is because, why? In the axial image, the table's not moving. The patient stopped, the machine collects a picture, and the table moves again. And it stops, and then we collect another picture. Helical, the table is constantly moving as the machine is constantly spinning and collecting data. So there's never a point where the the table is stationary, so there's always a little bit of a blur effect. Now, I would argue it's probably not that mission critical, that this is just a little bit of a softer edge, but you just need to understand that helical will have a slight amount of blur to it. So we're going to do a quick summary of what we've covered so far, and then I have a few more slides to go over. So bow tie filter, we want the right size bow tie filter, and we want to make sure our patient is always centered in the scan field of view. We want to pick the right KV for the right task. And as much as possible, it's good to use the lower KVs. We want to image as fast as we possibly can. That's in general. The faster we go, the better we can capture, or we can mitigate motion effects, especially in the chest, where obviously we can ask them to hold their breath, but more so we can help, we can create an image where the cardiac motion can be minimized or even frozen if you're going fast enough. We want to, somewhat of the benefits of KV, of reduced KV, there is dose reduction, which I will talk about, and there's CNR improvement, and there's potential for reduction of IV oral contrast concentration. So there's a lot of benefits for going to lower KVs. There's actually probably more benefits than there are negatives. Reduced KV is best, as I've kind of mentioned, best optimized for imaging techniques that has some kind of contrast being introduced into the body. Angiograms, enterographies, urograms, contrast enhance, of course, chest and pelvis. That said, there is zero benefit from changing 120 kV down to 80 or any other kV when you're doing a non-contrast image. There's just no benefit because there's just not a lot of inherent difference in the contrast to begin with in the image. All right, so these are all functions that directly affect image quality and the radiation dose output. And so we mentioned all the way at the very beginning, and actually talked about this a lot more last week, is there are certain reconstruction principles that we can optimize there are certain acquisition parameters that we can optimize that have no effect on image quality. And actually, forgive me, I said that wrong. We can affect image quality without changing the radiation dose of the body. So we can actually make a very big positive change without needing to worry about overdosing or underdosing our patients. And then there are other techniques that we just talked about that have a direct bearing on image quality and radiation dose. So let's talk about CT reconstruction principles. In general, CT reconstruction principles, they can affect patient dose in two principal ways. One is the type of reconstruction kernel we choose to use to create the image, to reconstruct the image. So as an example, when we're in the chest, when we're doing an we're going to pick like a lung kernel, the Canon, Siemens, they typically have their reconstruction kernels are numbered instead of just labeled like they are in GE. But the higher the value, the sharper the kernel, in those cases, we can actually tolerate more image noise in the image, and therefore we can actually reduce the dose to our images, and we don't have to worry as much about using a lot of radiation to create a good looking image with a sharp and edge enhancing reconstruction kernel. Now, if we're looking at really soft tissue, kind of low contrast objects, then image noise is going to be a really big issue. And so we need to maximize the contrast to noise ratio. And therefore, we typically need to use more radiation when we use some of these soft tissue enhancing reconstruction kernels. Now, the type of reconstruction algorithm that we use doesn't necessarily change per se with dose, but it can help us reduce our dose. And so the typical that we've used forever and ever and ever is filter back projection. We'll talk about that. Today, the standard is iterative reconstruction. And then as I promised a couple of weeks ago, I told you I would talk about deep learning reconstruction, which is the new, really awesome, amazing reconstruction algorithm out there that's going to change the way we look at CT, in my personal opinion. And those technologies, as we've gone from filter back projection all the way up to deep learning, they've allowed us the opportunity to lower our X-ray doses. And I'll show you how. So obviously I shared this with you. Obviously it was for the head, but I shared this with you last week, the idea that setting the various different reconstruction kernels directly affects how the image is created. And therefore we can actually tolerate a little bit more noise in this type of an image because the structure, the bony anatomy, is already got such a high contrast compared to the background. We don't have to worry about if there's a little bit more noise here. Whereas if we're doing soft tissue imaging, if you have a soft tissue lesion somewhere in here, a little bit of noise over that would just would obscure it. Sorry, my mouse is really sensitive today for some reason. I apologize. My slides keep going forward, progressing a little faster than I want on occasion. Okay, so I mentioned the reconstruction kernel is one, and then the reconstruction algorithm is the other. Just kind of looking at this little timeline here, the first CT scanner, clinical CT scanner, was back here in 1971. And from that time forward, basically till 2008, 2009, we used one reconstruction kernel, filter back projection. The main excuse me. The main reason for that is it was fast, and this was an era where computers were very slow. And when we moved into this new era of using iterative reconstruction, this required a much more intense computational power. And it wasn't really available to us until about 2010-ish, 2008, 2009, 2010. That's when computers got fast enough and powerful enough to introduce these new techniques. And then these aren't new per se. You know, you guys have been using them for probably better part of a decade on all your scanners. And each of the vendors, Canon, GE, Siemens, Philips, they all have their various flavors of them. So why did filter back projection last for so long? It was as fast as can be. We could make you could reconstruct head to toe hundreds of images in milliseconds, just very quick. But the biggest limitation for for filter back projection in CT is that when you create an image, filtered back projection, each one of the projected images, every angle that the CT scanner collects data as it spins around the body, every one of these angles, if it ever passes through a specific angle where there's a lot of noise, as an example, going laterally through our shoulders, that noise is propagated into every voxel, every pixel or voxel in the image. And it doesn't matter if you have an image, a projection that's going, say, anterior to posterior, which is going to be the least amount of attenuating in this specific slice, and therefore probably the easiest to penetrate and the least noisy or best looking image projection. But even though you have a really good, clean one projection, because you had a very, very poor projection on the lateral, that noise dominates. And so it doesn't matter how many good projections you have. If you just have one or two crummy projections, the image quality goes down. And that's why you have all of these streaking artifacts in filter back projection. So what we did is we introduced iterative reconstruction. Iterative reconstruction, its primary task was to reduce or lower the amount of noise in the image. And so when you look at, for example, I used, just as an example, we have Canon, so they use Aider 3D. They all have their different names, Acer V, Aider, Sapphire, Admire, IDOS 4. I know you guys have probably all of the major vendors also in Thailand. I know specifically you do in Bangkok because I've seen them all. And so irrespective of what they're called, these iterative reconstruction techniques, they did a phenomenal job reducing the magnitude of the noise power spectrum, reducing the variance or the noise in the image. And that's a wonderful thing. But an unintended consequence that no one saw happen until they put them on the scanner and we started measuring these things is, I remember when I first saw them, and the radiologist would say, these images look a little blurry. They look a little soft. And they couldn't quite figure out why until we started tearing into it and doing some fun physics. And we realized when you look at the noise power spectrum, the mean, the peak or mean of this filter back projected spectrum shifted left. And so here you see the mean is lower. Therefore, the texture changed also. You're going to say, okay, well, it's fine. The texture changed. Why is that a bad thing? If you look at the way our eye responds to resolution, our eye is optimized for this middle to kind of higher resolution range. When objects are too close together and too sharp, our eyes actually lose a little bit of sensitivity to the, our ability to distinguish those edges. But it's even worse when the edges get blurrier and more coarse. And so this lateral shift to the left of these curves simply put the reconstructed image distinctly in a region where our eyes, more specifically the radiologist's eyes, have a harder time perceiving edges or resolution. And so that is why the image quality, as I'll show you in a minute, actually looks just a little softer in iterative reconstruction compared to filter back projection. All right, so to overcome that, fast forward 10 years to, well, basically last year in 2019 and 2020, we came out with these new deep learning iterative reconstruction techniques. And what is deep learning? It is just a fancy name for a computer algorithm. Basically what it is it's a network of it's software that tries to mimic the way our brains work. Our brains have obviously lots of little neurons and nodes all firing. And so when I'm moving my finger, I'm getting a lot of electrical impulses that go up and they fire, and there's a bunch of neurons that work, and they all work in concert so that my body will know how to move or talk or think or breathe. Well, we can create software that has these same type of neural connections. And so it has a way of taking an image, decomposing it into its most basic structure, learning about that basic structure and putting it back together. And that's what a neural network is. So deep learning is that network right here. And what we do is we need to train that network. We need to train it to find something specific. It's one thing to just take that image and break it down to its teeny little pixel values and then put it all back together. But if we do that, and as we're taking it apart layer by layer by layer, and we're trying to teach it to find something, for example, noise, then the system becomes exceptionally good at figuring out what is noise and what is not. And so we train the system by giving it a lot of really good looking, high quality, low noise images. And we give it those same images, but very low quality, low dose, just ugly. These are images out here on the left that no radiologists want to look at. And as we send both of those images into this neural network, the system immediately goes, oh, I know what's different. It's the noise. And so we've trained this network. Now, when the patient climbs on the scanner, goes through, it takes the image and it immediately takes it apart and goes, okay, here's the noise and here's the anatomy. And it puts it back together without the noise. And that's basically what deep learning is. And it's just phenomenal in the quality and the direction we've been able to go with our iterative reconstruction over time. So filter back projection here on the left. There are two different flavors or styles of iterative reconstruction. Primarily the one you use and everyone uses is something called statistical iterative reconstruction. And so it's like your AIDRs, your ACER-Vs, your Admires and whatnot. There are other ones out there that tried to harness more power. They just kept trying to add to it to make them better. And I would argue that this image is a little bit more coarse. It's blurrier. The pixels tend to be more blobbish, more smudged. And so the overall pleasing nature of this image is a lot lower compared to, obviously this is too noisy, but the edges are sharper and crisper over there. So what if we can just simply take that noise out, but not affect the edges? And that is what deep learning's done. And here you can see for a 3 millimeter reconstructed image, this is what you would probably, this image right here that I'm circling with my arrow, that is what our radiologists looked at consistently for a decade, from basically 2008, 2009 up to 2019. And when we were working with Canon on developing this, we got these images here, and you can see here now just the quality of the image. It's reduced in dose, and it's even improved if you looked at the thinnest of images, the 0.5 millimeter images. Yeah, still a little noisy, but compared to where it was, it's just so much cleaner. So let's drill it down. Compare it to where we were a year ago to where we are personally now today. So by simply just turning on this algorithm, it works on top of all the other algorithms that we have going on. Filter back projection. The very first image the technologists see on the console that appears in front of them, that is always filter back projection. And then iterative reconstruction cleans that up within about 20, 30 seconds. And so they're seeing a cleaner image. And then the images that we oftentimes will send to the radiologist will be these nice images, but noisy. And then we apply the deep learning on top of that, and we get this nice clean image. Now, did deep learning, what was the biggest benefit? Well, I mentioned that when you look at these deep learning images, high versus low, it's simply finding the noise and removing it. And so there's really no edges in here. You can't see an outline of a bone or an outline of the myocardium, the lung area, and I guess, yeah, the heart and whatnot. You don't see any outlines here in this noise plot, which means that the edges were never subtracted, never removed. It's just simply the difference between these two images, the higher dose, less noise, and the lower dose, noisy image, is simply the noise itself. So it is very good at finding noise patterns and removing them. These deep learning algorithms are built up, and they are have been inserted into the iterative reconstruction process. So therefore, we actually call them deep learning iterative reconstruction algorithms. There are two major vendors out there, GE and Canon, that have this algorithm for sale, and it's something you can eventually put on like your Genesis and your GE Revolution or Apex scanners. And these two vendors come with multiple different options. Usually you can apply a mild, a standard, or an even stronger amount of noise reduction. And so for some people, this may look a little it may look a little foreign because there's not a lot, if any, noise overlaying this image. And they look at this, and most radiologists would see this image and they feel more comfortable with it, even though the only difference between these two images is the noise variation, but it just gives it more of a pleasing look to the eye just because that's what they've been trained to look at. And so most places have been just immediately using the standard or the middle option, medium or standard. Canon additionally created different reconstruction algorithms for different parts of the body or different applications such as body, lung, bone, or cardiac. And so then the other question is, we've been talking about how these new technologies, they've improved spatial resolution, they're reducing the noise power spectrum effects, they're improving contrast. These are all quote unquote physics metrics that we've talked about that make sense to us when we're trying to ask the question, is this algorithm, is this protocol, is this scanner better than something else as a comparison? But the real question we really want to know is, do all of these changes have some kind of direct correlation with the improvement in detection accuracy, radiologist sensitivity and specificity, and classification and detectability? And so this side of the equation is, how well does a radiologist perform if we modify these objects over here? So now that we have all these new technologies, one of the things we've been trying to do is we're looking at various different applications, and we're going out and we're starting to ask ourselves, do we improve detection sensitivity? As an example, we just looked at a very simple task with something we wanted to know. And so we looked at being able to count stones in the kidneys. Were they able to detect, have a greater efficiency or sensitivity to detect stones of all different sizes, and did it change the number of stones that they could detect based on the various different deep learning algorithms out there? So we did a reader observer study where we took in this case 3 radiologists. We had them look at 84 total exams, basically 14 patient exams that we reconstructed using the various different strengths and different types of the deep learning iterative reconstruction algorithms. And in our case, of course, we're pediatrics, so the preponderance of our kids were late teenagers. And the values that we found for the radiologists was they almost agreed completely in every case. A kappa value of 0.7 and a 1. Basically, a kappa of 1 means there's perfect agreement. And so there were times where they perfectly agreed on all of the images, on some of the images they looked at. In other case, there was slight difference, but a kappa of 0.7 is a strong agreement. So it's anything over, I think, like a 0.6 or a 0.55. This is a very strong, good agreement. So in this case, we found there was really no statistical difference between the old way we did it with the iterative reconstruction and the deep learning. So not quite necessarily the slam dunk or the, for us, kind of the home run. We didn't really see a great improvement in detection sensitivity. Mind you, this was looking at a high contrast object, such as a stone. There are other projects, of course, since it's such a new technology, we're looking at all types of things, tumors and, metastatic disease, infection, all this subtle stuff that we see see in the body that may be improved by the use of these new deep learning algorithms. So summarizing what we've been talking about with reconstruction algorithms, iterative reconstruction has fundamentally replaced filter back projection. And I would argue probably in the next 5 years, deep learning algorithms will fundamentally completely replace iterative reconstruction algorithms. Advantages, of course, they reduce image noise, they reduce image artifacts. The disadvantage that I demonstrated was noise texture changes. Images can be softer and they will appear softer to our eyes just because of the way our eyes work. And I didn't really talk about this, but they do take a little bit longer to reconstruct. I alluded to it because we needed faster computers. I would argue that even though it's a disadvantage, it's not that big of one. It only adds maybe 40, 50 seconds to your reconstruction time. Something that a radiologist will never see, because by the time the scan is complete, and send off to PACS, and the radiologists have a time to go through their work list and pull it up. That's not an issue. We're talking minutes to tens of minutes for a radiologist, whereas on these scanners, we went from seconds, milliseconds to maybe a couple seconds to a couple minutes. And then, like I said, deep learning iterative reconstruction advantages. They once again also improve the image noise artifacts even more so than iterative reconstruction. And we haven't really found any true impact on, the diagnostic ability, the sensitivity, but I'm sure we'll find that as we continue to go forward. All right. This talk was a little bit longer, and so my next talk won't be as long. So I know we went over a little bit in our timing scheme. And so if we still want to take the full amount of time for questions and answers, I just wanted to let you know, Tanya, that my next talk is actually not going to be as long, so we'll still end on time total.
Okay, sounds good to me. Thank you so much for simplifying things for us. Yeah. So ถ้าใครมีคำถามนะคะสามารถยกมือขึ้นมาได้นะคะใน Zoom แล้วเดี๋ยวจะเปิดให้สามารถพูดได้นะคะ So any questions that you guys have, you can type in the chat box or also raise your hand and I can unmute you. And today we also have Dr. Panrutai who's going to join us as a moderator for question and answer session. I have a couple questions. So for clarifications, I think the main things for us as a radiologist, we want to detect the lesions. So which means we need a good signal to noise ratio. And there are many ways to make a good signal to noise ratio, including low KV or increased the iodine concentration on the images, right? And after that, we have like a multiple physics stuff, maybe like a pitch or scan and everything. But the key things that we need is good signal to noise ratio. Is that correct?
Yes. When it comes down to, if you have a lesion that is enhancing, so we've got iodine on board, one of the best ways that we have found over the last couple of years is to reduce our image with lower KV. And probably 10 years ago, our scanners couldn't do that. They weren't strong enough. They weren't powerful enough. But nowadays, the more modern scanners, they have the ability, the generators are strong enough that we can put out enough MA, which we're going to talk about, because when you go low KV, you do need to increase the overall amount of MA or your image gets real noisy. So if you don't fix your MA, the lesion might be more strong. That signal might be stronger, but it would just be obscured with noise. And so we have to make sure we keep the image noise down, but with that lower KV, the conspicuity of those lesions will just kind of pop out a little bit more. And so two things, we lower our KV, which is a great way to go. And then as you have the ability in time, you obviously have iterative reconstruction now that cleans up noise, but with the deep learning algorithm, which is really kind of the future in the next couple of years, I think everyone will have that. That is going to, because that takes the noise completely out of it. It might take a little bit of our radiologists learning to look at a slightly different image. They are going to have to kind of recalibrate their eyes a little bit to look at an image without noise. But once they get used to that, I think they're going to start seeing even just small micro findings that they're not used to seeing, because they always would say, is that noise or is that a lesion? Is that infection? Is that noise? But now that you take that noise out, hopefully it becomes very obvious, even if it's not enhancing and like certain lesions are.
So that means in the future, when we have a good imaging reconstruction like deep learning, we can even lower the radiation dose to the patient because we can do like a post-processing technique.
Yep, I'm definitely going to talk about that in my next talk, but the answer is yes, we can do that. So yes, if we want to continue to reduce, quote unquote, the risk by reducing radiation, definitely yes. I would argue, and that's why I'll show you some pictures, I would argue we're kind of pretty low dose already. Most of the time, I mean, Dr. Panrutai and everyone did a great job when we reviewed the Thai DLR values. Mm-hmm. Thailand, when you compare your national DLR values, you were kind of at the middle or actually lower than most of the countries around you. You know, when you looked at Japan and a few others, they were much higher, and you know, South Korea was a little lower, but for the most part, you guys are doing great when it comes to radiation dose. Can you improve a little? I'm sure we can always improve, right? Now, the whole goal of the DLR program in Thailand is to get all of the hospitals all over Thailand to try to conform to that national value. And once you all are kind of in that value, in that range, then you know, quote unquote, your risk is pretty equivalent, and I would argue decently low for all Thai people. And so we want to keep it, you know, that's the whole idea of DLRs, is to try to keep the risk the same no matter where you get your imaging. Now, you may say, yeah, it's high, it's okay, but could we go lower? And we'll talk a little bit about that in the next talk, but there are times when we just don't need a lot of radiation to image. In other words, we're looking at, let's say we're looking at coronary artery disease. And so we're doing a calcium score. And we'll talk about cardiac next week. So it's probably a bad example. But calcium scoring is a very easy thing to see because it's contrast enhanced, and there's calcium, you know, calcification in the vessels. And so it just pops. We don't need a lot of radiation. Now, on the converse side of that, let's say we have a patient that presents with an infection, you know, fever, they have all these other issues. So we're thinking maybe there's, maybe could be cancer. So we did a scan of the abdomen. We're looking at the liver. We're looking for low contrast, small mets. We're maybe even looking for, if we have a patient that's been on chemo, we're looking for infection, small and focal spots for infection. Those are things that those are just hard to see. And so what is the risk there? Well, the risk is missing the radiologist missing the disease. And so that case, then maybe using a little bit more radiation is probably okay. It's actually probably the best thing to do. And so that's why that deep learning and iterative reconstruction, we can do it both ways. We can improve the image quality and get what we need without changing the dose, or we could actually keep the image quality where we're at and drop the dose some more. But I have some slides on that. We'll go over that in a minute.
Okay, sounds good. มีอะไรไหมคะ
There's a question in the chat from the audience.
All right, let's see. Regarding the bow tie issue, if we want to image the spine that located posteriorly of the body, we should position the torso at the center of the position, or position the spine at the center of the gantry. And then they also ask, as well as the cardiac bow tie, we should place the patient at center or place the heart at the center of the gantry. So those are great questions. So let's start with the first one, the spine. So we all know, yeah. So when we image and we place the body at the center, the spine is actually going to be a little bit lower. Now, if we center it on the body, what's going to happen, and we're going to talk about that in this next talk about the dose. If we center it on the body, that means the overall body will get the right amount of dose. If we push the patient up so that the spine is centered, what we've actually done is we've increased the overall dose to the patient. And I have some examples on that. So I'll show that in a moment. And so what we should do is we should always center the patient. Now there are times, and so you'll center the patient, and that will keep it so you don't get those imaging artifacts. If you have it a little too low, then especially if you're doing, you know, spine imaging, you get that streaking artifacts, and that just doesn't look good, especially when the radiologist is trying to read through that. Now, the caveat to that is when they built these scanning tables, they made them so that they're curved, right? They thought they would be more comfortable for patients, and they probably are, instead of laying on a flat, hard surface. But the problem is when they made them curved, our bodies fall into them. And so technologists are really good at this, but when they go in to line up the patient, there's going to be a part of the body that's literally below the surface. And so it's hard to know exactly where is the center of the patient. A lot of the newer scanners, and I didn't show this image because it's really only on the newer scanners, they will, when you do your localizing CT, it will tell you where the center of the body is, and it will tell you where the center of the gantry is. And so if they're not lined up, you can push a button on your scanner and it'll move the table up or down. or you have to walk in physically and move it up or down. But that's nice. So going forward in the next probably 5 years or so, every scanner is going to have that, where you'll go in, you'll get them as best as you can centered on the scanner, and then you'll walk out of the room, and then you'll scan, you'll do the localizer, and then the system will know to move it up or down. But I have some more examples of that, so we'll kind of talk a little bit about that in the next one. But then the other one is the heart. And that is kind of tricky, is because you really want to, you have to get the patient centered into the body. If you off-center the patient, well, I guess you off-center them this way, so you get the heart at the center. Well, the problem is, if you look at it now, my body is off-centered to the bow tie. And by off-centering to the bow tie, you're actually going to increase the amount of artifact at the edges of your body. And so if, even though you've put the heart at the center, you're actually putting a less thick part of the body centered over the thinnest part of the filter. And so it throws off the way the image is captured at the detector. And so it's still best to keep the body nice and centered. So centered up and down, left and right. And from that, then you can go in and you can set your field of view. You know, you might actually only set your field of view around the heart, or you might set your field of view even thinner around the spine. But always keep the body itself centered.
So does it mean we need to put every patient in the center to reduce artifacts and reduce radiation dose, have optimal radiation dose to the patient, and then we can adjust or change the display field of view to get a better image, to see more detail?
Yes.
Yeah.
And about the same question for the baby, very small, and the table cannot move up to the center. So how do you manage that?
Yeah, we used blankets. When you have a teeny little kid and these tables have this big bow to them, you put the baby into it, the baby disappears. And so, yeah, when we have little kids, we will actually, I've seen some places, some hospitals will actually use a flat table, but that's just that's hard, because then you'd have to change the tabletops. What we do is we just put a couple blankets down. So when you put the baby on it, they don't sink down into it. They just sit on top of the blankets. You just need to make sure you use blankets though. If you're putting something in there that's heavy or hard, then it could cause artifacts. But blankets are, they're air equivalent, and so there's not an issue.
Another interesting questions from the chat box. Yeah.
Yeah, there's another question.
For the low KV technique in CT that help to enhance the iodine enhancement, the question is, in case of chest and lung screening protocol, which is non-contrast study, should we use the low KV or the conventional KV at 120?
It's a good question. So if you are doing a non-contrast image, a non-contrast CT, if you lower the KV, you are not enhancing the contrast. There's just nothing to enhance. And so there's nothing to change. It's all the same, basically, CT number. The only reason you would want to use a lower KV in screening CT, so this is where you're doing a screening CT, where you're trying to do the lowest dose possible because you're imaging a very large amount of people. This is the one example why using a non-contrast CT, you could use like an 80 kV. And that's only because you're reducing the dose. If you go from 120 down to 80 kV, you're not going to enhance the image quality, but you are going to reduce the patient dose. And we will talk, unfortunately, we haven't talked about the dose yet, but we will talk about that in the next talk. So I did say that there's really no benefit to lower KV for non-contrast. I would say that there is no benefit for low KV imaging when you're doing, for example, a non-contrast abdomen or non-contrast pelvis, because we don't really screen. We don't do CT screening for abdomen pelvis. But in the chest, that's become very common, for smoking and whatnot, for lung disease. We've been, most places, especially in Thailand and the US, we do CT screening of the chest. And so we do really, really low KV, low MA, And it's okay because the air in the lungs and the, you know, the lung tissue, it's already so contrasty, so different that you as the radiologist or you radiologists are able to still see if there's a if there's a little nodule or there's something in the lungs, even if it's a low quality image. So that's a great question, and thank you for clarifying, because you may have misinterpreted what I was saying when I said don't do low KV for non-contrast images.
It's normal populations, and we don't want to give too much radiation to the normal population, right? That is the key.
Yeah, and especially if, you know, if there is, you know, if they have a history of smoking, and now they're going to start going in, I don't know, once a year, once every other year, depending on what the protocol is. If they're going in to get a CT chest all, you know, for the next 20 years of their life, we don't need to use a lot of radiation. We don't want to, especially for women. You know, obviously they have breast tissue that's more radiosensitive. And then we all know that most of the tissue that is more sensitive to radiation, lung, breast, stomach, we got a lot of that in the chest area. And so we have to be a little bit more cautious when we image the chest.
May I ask a little about the kernel? I don't quite understand that. Is it applied before scanning or after scanning, or can do at either of them when we select kernel?
Mm-hmm. So when we select, so the kernel, the beautiful thing about reconstruction kernels is when we acquire the image, we can actually go through and change it. In fact, you as a radiologist, you could see the image and say, oh, I want to see something different. And so you could actually ask the technologist to change the kernel and send a new reconstruction to PACS for you to review. So the caveat to that is, go ahead, Panrutai.
I would like to know, can we say that we want the kernel first from the beginning before the scanning?
Yeah.
Right?
Yeah. So yeah, the caveat to that is if you're going to do a soft tissue reconstruction kernel, you need to set the dose at first to match that kernel. And so that's where you have to understand the task. If I'm going to be imaging the abdomen, well, I'm primarily looking for soft tissue. Yes, you're probably going to do a soft tissue and a bone. So you can look at maybe if there's any trauma or something to the bone, or the pelvis, for example, would be soft tissue and bone, and lung. I mean, the chest would be soft tissue and lung. But primarily the primary task that you're going to use that image for, you need to set the dose and the kernel to match.
And if the clinical task, they want to see everything, want the high-res CT, chest, and also want the soft tissue, what should be the setting kernel in the beginning?
Yeah, soft tissue. And that's just because soft tissue is more dose sensitive. So if it's if you didn't use enough radiation in a soft tissue image, it's very noisy, right? And so if you have a laceration or you have internal, well, bleeding is easy to see, but you have some kind, you got a laceration of the spleen or the liver or something from a trauma case, you need to be able to see the soft tissue damage. Now, if you're going to do soft tissue, bone, lung, you're going to have multiple different kernels. Well, that's okay. Even though we set the dose to the soft tissue, the bone window will be okay. It'll just actually look a little better. And so will the lung. If the primary task is the lungs, for example, if you're doing a lung screening, then we would optimize the dose to the lung kernel. And then if the primary task is, I don't know, let's say MSK, musculoskeletal, then maybe it's bone. And in which case, soft tissue is a secondary look. Now, I don't know if that's true for certain, but for your question, I would almost always optimize it to soft tissue. because that's the hardest to see.
Thank you.
Yeah.
That's good. So you can move to your next talk and maybe,
Okay.
yeah,
All right. All right, so let's go on and talk about radiation dose. So, as I mentioned in the last talk, we were focusing on image quality, but there is a subsection of image quality that is affected by radiation dose. So, if you, for example, change the tube voltage, you know, the MA, the pitch, well, the pitch is a small way, but like the detector coverage, you do change some of these things, you will affect image quality, but you'll also affect radiation dose. Excuse me. And the other thing that it's going to be, the other thing that will affect the radiation output is the actual patient themselves, you know, how big they are, how much they weigh, and certain factors that we need to take into account when it comes to risk, such as maybe age and gender. These are all part of this optimization effect, that optimization question that we need to consider now for the dose side of the equation. So we're going to talk about basically the same concepts that we just talked about earlier, you know, the bow tie filter, KV, all these things, but how do they now affect image quality? Excuse me, not image quality, but radiation dose. So to ask the same question I started out with in the last lecture was, how constant is the radiation output on the system? So we saw in my first plot of noise, it was pretty constant over time, which means that the system is giving the same radiation dose. If you type in, you know, 100 MA, it's pretty consistently always giving 100 MA. So I asked the same question now, how does the CTI value vary as a function of KV? 80, 100, 120, and 135 are the 4 standard outputs for our CT scanners. And looking at, once again, over approximately 340 days in 2020, the outputs for those 4, when I typed in a very specific number, were constant. And that's good. That is a very good thing. This is something that's important for you guys to establish. This is kind of where your medical physicists will make sure that the system output is always constant. Because if there is variation in the machine output, you can go in and you can set your protocols. You can optimize your reconstruction kernels for soft tissue. You can get the right KV. You can do everything right. But if the machine is variable, your output, your image quality, all that's variable too. So always go back, make sure your systems are constant. And these systems, these scanners, they really have been, obviously they've been built since the 70s, and, you know, fast forward almost 50 years, these scanners are really good scanners. And so I would say that, yes, they are pretty constant. And so we should have a lot of confidence in the way we image. All right, I alluded to the fact that when we consider radiation dose optimization, probably one of the biggest ways we can reduce unnecessary radiation dose to our patient population is actually to ask not how low can we go, but where should we target the use of radiation? So what is the right level of radiation dose? What is the right level of image quality? So here's just an example. If I need to see this leak right here, can I see that in this quality image with a CTDI vol of 2.76 versus the exact same, but now imaged at 14.2? Did we change the diagnostic confidence? Do we change the sensitivity and specificity of our radiologists by reducing the dose by a factor of 7? The answer is, I assume, no. I'm not a radiologist, I have to openly admit, but I can basically see the same leak in both of these images. And so in my naive eyes, I don't think this patient needs 7 times the radiation dose for the task. And so being able to tailor the right amount of dose for the right image quality is probably one of the more crucial questions that we need to establish in our optimization team. And that's why we need a radiologist, we need a technologist, we need a physicist, and we need some computer IT specialists. All right, so now let's get back into the specifics. So we talked quite a bit about the bow tie filter. Why is it essential that we put the patient at the center? More so than putting the anatomy we're imaging at the center. So we're not centering it on the heart. You know, we're not pushing the spine up or down. We want to put the patient at the center. And here is one of the reasons why. If I so here in the center is a nicely centered patient. So we do our localizer CT. Here we did a nice anterior posterior. We can see the image, arms up. Okay, that's great. The CT, the technologists will be able to go and put their scan field of view on this, and they can plan and they can go forward with that. But what happens if the patient was accidentally put a little too close to the X-ray tube? So they're off-centered high. Well, if you off-center the patient high, and then we do that same localizer, the patient actually physically looks larger in this image than this image. And that is because of the magnification artifact. If you have a detector here and an X-ray tube here, the closer you get to the tube, X-ray tube, or the farther away you get from the, the detector, the bigger the patient looks. We see this all the time in planar radiography. When the patient goes up and hugs the detector and we're doing a PA chest, well, the heart is bigger. If we flip them around and do an anterior posterior, now, their backs to the detector, their heart's smaller. Yeah, it's the same effect. But as we will talk about in a moment, the system plans how much radiation to use based off of the localizer. Excuse me a second. Sorry about that. I had a frog in my throat there. And so when this patient looks bigger, obviously physically they're not bigger. The patient's actually the same size as you see here, but the system is now going to plan to use more radiation because it appears bigger. So if we had centered on the spine, well, the spine would be in the center, but the overall patient, the bulk of the patient, most of the abdomen and the chest would be higher up. Therefore, it would appear bigger. So that patient would overall get more radiation dose. Here, I just simply took and I measured, I took my ion chamber and my phantom and I moved them up to 50 centimeters too high. And then as I go left on this plot, I lowered them basically 50 centimeters lower. And so you can see how the radiation dose changes. And this, I used an adult phantom and I used just a pediatric 10-year-old phantom. And so overall, the dose goes up much faster when you go too high than if you accidentally put them too low. And so this is kind of that, my apologies. Dr. Panutai mentioned what happens if you put a little teeny baby on the scanner and you don't build it up, put blankets, they just kind of sink down. Well, that means they're going to appear, if they're too low and the scanner is, the patient is too low, closer to the detector than the X-ray tube, they're going to actually appear a little smaller. Now, the system will think, well, if it's smaller, I don't need to use as much radiation. So the patient actually will get less radiation. So maybe that's a good thing, but the noise will go up. And the good thing, I guess, is if we're off-centered too low, the noise doesn't go up that fast. It's only just a little bit off. But if we go up even just 5, 10 centimeters too high, you see here 5 centimeters too high, the dose goes up really quick. And so getting the patient centered is more crucial for the radiation dose, I think. Yes, it prevents the artifacts that we saw in those spine phantoms in my previous talk, but also by just getting the patient wrongly placed in the scanner really truly affects the patient dose output. All right, so the next thing I want to talk about is setting up the right acquisition factors. So we're going to I'm sorry, this slide is out of order. I thought I had moved this slide when I prepared my talk. All right, I will explain this slide, but it's actually, this slide is meant to go in when we talk about reconstruction. My apologies, this is out of order. All right, when we go to set up how thick we want the image when we give it to the radiologist to look at, you know, standard for an abdomen, it's going to be somewhere around 3 to 5 millimeters. So in the z-axis, that means we're averaging 3 to 5 millimeters of the patient together, and that's what we see transaxially in this image. Now, every system, when we use automatic tube current modulation, every system uses a value that establishes how much noise we will allow in the image. So for example, GE uses noise index or NI, Canon uses SD for standard deviation, Siemens uses the quality reference mass, Philips has something kind of similar to that too. That's why I didn't list theirs. And so if you go in and you say, I want a noise index of say 30, and I'm going to, in the end, have a 5 millimeter thick image, the system knows how much MA to use when they do the tube current modulation as it spins around the patient. And you get the image on the right-hand side. It looks nice, I hope. I think you think that would look good. Now, what happens if we use that same noise index value, but we reconstruct it at a different thickness? In this case, the thinnest we can go on a GE scanner is 0.625. Obviously, the image is much, much noisier because the radiation output was assuming that we were going to average up to 5 millimeters of tissue together. So so Dr. Panrutai was kind of asked this question about the reconstruction kernel. In a similar way, we have to, when we sit down to optimize our protocols, we have to think, well, how thick am I going to want my images? Do I want the end result to be, say, 5 millimeters or 3 millimeters? And if I do, then when we program in the right noise values, the target values, then the system can pick the right MA. And so my apologies, that's a little out of order. Hopefully we can talk a little bit about that again when we get to reconstruction. So we had gone from, originally we were talking about the bow tie filter, and then we talked about KV. So we're back to KV. So let's talk a little bit about KV and how that changing, going from 1 KV to another, how does that affect dose? Well, I mentioned that as you go, you can kind of see from this plot, if you go from 1 KV value, say 135 down to 80 KV, the machine output, in this case CTDI vol, decreases exponentially. And so this assumes a constant MA. So if I'm using 100 MA as an example, but I change the KV, the dose output considerably comes down. And so this is one of the benefits of using low KV. Now, we already talked about how it improves the contrast. So why does the dose go down when we use KV? Well, we know, mathematically, KV changes as a quadratic. It's a square value. So let's take an example here. If I want to reduce my KV from 120 to 80, so I reduced it by 40 value points. So if I divide 80 by 120 and I square it, I get a reduction, a dose reduction of around 56%. We know that MA, or radiation dose, it changes linearly. So if I make the same change, 80 MA versus 120 MA, but because there's not a square value, it's not quadratic, I actually only get a 33% dose reduction. Now, this is a benefit. We're going to talk about this in a minute. But the fact that the KV changes dose faster than MA changes linearly is a benefit to us. Now, the converse happens. If you're going higher, if you're going 100 to 120 to 135 or 40, the higher up you go, the faster dose will increase. So just a comment, just as, you know, this is just a physics property, a principle you need to remember. When we change MA, it affects dose and image noise. But when we change KV, it affects dose and image noise and image contrast. And so changing that MA dial doesn't really adjust the contrast we see in the image. So we've already talked about how imaging with low KV, and I actually showed this with my one plot of phantoms, the lower the KV you go, when you keep MA the same, the images just get noisier. And that's because as we go down in KV, the photons coming out of the X-ray tube are less energetic. That means they don't penetrate as well. Now, it's a good thing in the sense if they don't penetrate as well, they get absorbed easier in things like bones or iodine contrast in the liver parenchyma or, you know, in our vasculature. And so we get a better contrast, inherent contrast in the image. But that means we get less photons at the detector, and less photons at the detector means our image quality doesn't look as good. So what we can do is we can take into account the fact that KV dose changes faster with KV than it does with MA. And so if I have a value here, I'm going to image, if my protocol is currently established at 120 kV and the average value is 100 MAS, let's just say it's 100 MAS through the body. If I go in and I measure the noise content, so I put an ROI kind of somewhere in the center of the body, the value is going to be somewhere like 7.6. It's just an example. The output, the radiation dose or the CTD volume CTDI value is, in this example, when I scanned this phantom, was 6.8. Now, I want to do that same change. I want to reduce from 120 to 80 kV. Now, if I hold my MA output the same, well, yeah, look, the image is less appealing. It's noisier. My noise content went up. Now, I got a great dose reduction, as we predict, but the image quality went down. Radiologists, as much as they are all about lower radiation dose, they are not all about reducing their image quality too. They need to still be able to do their job. And so what happens if I reduce down to 80 kV, but I keep my noise roughly the same? Well, the only way to keep the noise the same is I have to actually increase my MA or my output, my radiation output. And so I did increase it. But because KV changes as a quadratic, whereas MA changes linearly, look at my volume CTDI. It didn't go up as fast. So 80 kV, I will have better image contrast. My iodine enhanced contrast tissue will pop better. I'll be able to see smaller structures that are contrast enhancing better. The noise content will be mostly the same, but I did get a dose reduction. And so that is one of the benefits of using lower KV. All right, so let's move on. What we talked about, I already showed you this slide. We talked about using in helical mode, imaging in helical mode. So I asked this question, but I did not answer it. I said, does pitch affect patient dose? So if I'm imaging at a high pitch, there's areas of the body that are not being exposed. So you would think, oh, it's lower dose, right? And there are, if we do a pitch less than 1, we're imaging certain parts of the body twice as it spins through going really slow. So you would think, oh, well, wait a minute, radiation dose must be higher. And the answer is, that is not correct. I mentioned to you, all of our little kids are imaged at pitches less than 1. So that would mean every one of our little kids were being overexposed, but it's not true. So why is that? It's because when we turn on our tube current modulation, we have to tell that algorithm, we have to tell the software how much noise we want in the image. Remember those values, NI, SD, that quality reference mass, QRM, which is a Siemens one, but it's kind of the same for Philips. So those 4 values, you as a optimization team, radiologist, technologist, physicist, potentially a computer specialist, you need to be able to decide how much noise is acceptable in an image. When you set those values, then the system will tell, the algorithm, the software, the protocol will tell the CT scanner how much MA to use. So if I have a pitch of less than 1, the body is being scanned or oversampled in some places more than once. Therefore, it doesn't need as much MA per rotation. So it will reduce its overall amount of MA. If the pitch is greater than 1, that means there are times when certain parts of the body are not exposed at all and other parts that are exposed. Well, if we're going to be averaging the data between 2 adjoining sets of data, well, those 2 sets of data need to be high quality. And because they've been partially undersampled, we need to actually increase the MA. So for pitch values greater than 1, MA is increased. The net result is that noise and radiation dose is the same when you look at it across the whole field of view. So pitch less than 1, we're oversampling, but the dose is lower. So we keep the same noise and the same total dose to the tissue. Pitch greater than 1, well, we have to increase it a little bit, but that's only increasing it for part of the patient, not all of the patient. And so once again, noise is the same, dose is the same. Only if you go way back in the day, and I don't know if you guys have any CT scanners that are single slice anymore. So not the multi-slice, multi-detector CT scanners of today. You go back in the late 90s and early 2000s, back when they had single slice CT scanners, that was when pitch changed dose. If you have a single slice CT scanner and pitch is less than 1, dose goes up. If pitch is greater than 1, dose goes down. But it's only for your single slice CT scanners, which admittedly most scanners are not today. I don't know if you have really old scanners somewhere in some small little clinic out in the middle of nowhere. If you do, then you have to be careful. Changing your pitch will definitely change your dose. But for everyone else, you set the right pitch to get the right quality of image you need. All right, so when you break it down and you look at all of the tools that we have in CT, bar none, the tool that gives you the best dose management is tube current modulation. And so we want to make sure we get this one very well optimized, especially for the body, because we really have to modulate because our body's changed quite a bit from the chest down to the abdomen, lateral compared to anterior posterior. We are elliptical by nature. And so therefore radiation coming down anterior posterior versus laterally will be very much different. And that is where tube current modulation really is one of the most amazing pieces of technology on the CT scanner. As the machine, as the gantry, as the X-ray tube spins around the body in one single plane, the system is able to reduce the amount of MA and increase it very quickly to the point where it can sculpt and it can put the right amount of radiation dose through the patient at the right thickness. And this is a way to keep the same amount of photons at the detector no matter how thick or thin the patient is as it spins around. And the whole goal here is not necessarily just in one image, but obviously as we go down through the body, so through Z-axis, as we're constantly spinning around the various different thicknesses of the body, we're trying to keep the noise basically the same as we go from various different thicknesses of the body. Now, we've talked about how tube current modulation, it modulates as it spins around our body, which is why you see in this curve, you see the constant ondulation or constant variation going up and down. The top of this this curve represents the thicker, kind of the lateral sides of our body. And the lower body, the lower part of this curve represents the thinner aspects, maybe the anterior, posterior. But also, obviously, as we know, as you're going through different parts of our body, you know, through the shoulders, we're real thick, so we need a lot of output. But then when we get into the larger part of our chest, which is mostly air, we really don't need a lot of radiation. And then abdomen and pelvis gets into some soft tissue and bony. So we're able to change the amount of radiation as we spin around our body and as we go through our body. You guys know this. That's tube current modulation. It's been around since the mid-90s, and it's standard. Your system has tube current modulation. If for whatever reason you are still using fixed MA protocols in the body, I would challenge you to consider changing those protocols. We talked about there are times when they're okay. You know, for example, we use those in our head. But like I mentioned at the very beginning of today, the head is pretty constant for all patients of similar age. And so you can kind of get away with using 1 MA and 1 kV for a specific protocol just because that head is going to be the same. But my chest, my abdomen is going to be different than your chest and your abdomen. And so you really want the system to be able to modulate and spin around. All right, so how do the various different vendors set up their dose modulation or their tube current modulation? I thought it would be important to talk about this just so you understand how they all function when you set up the parameters. Because I mentioned once you have to set up those noise index parameters, NI, SD, the quality reference mass that they use for Siemens and kind of like they do in Philips. You need to know what to set for what type of image you're going to get. And then you need to understand how the MA is going to change and how the noise, which I'll show you on the next slide, is affected by it. So there was this paper that came out. If you go to mhra.gov.uk, this is a study that came out from the UK. They used this conical plastic, or it's a plastic phantom. In other words, it's a constantly changing diameter phantom. And so that's why you see here along the x-axis different patient diameters, going from really teeny, 5 centimeters, which is not even a patient, maybe an arm, up to relatively thick, 250, 300 millimeters, or 25, 30 centimeters. So the thicker or the more attenuating patients are on the right side, the thinner on the left side. And then along the y-axis is machine output, tube current or radiation dose output. So if we dial in a constant MA, obviously, you get a constant plot right across horizontally. Now, you get these curves. So I'm going to focus on GE and Canon. They basically have the same idea. GE calls it the noise index. Canon calls it the SD, or the standard deviation. It does the same thing. And so you're telling the system how much noise you want in the image, and then the system will pick the amount of output or radiation. So if you dial in, let's say, a noise index of 10 or a standard deviation of 10, and your patient is somewhere over here, let's say 20 centimeters, well, this system knows for that slice thickness, it's going to use about 150 MA. Now, obviously, you're going to be moving up and down this curve. As the patient gets thicker, say in their abdomen and pelvis, it's going to go swing higher and use higher MA. And as they get thinner, or maybe through the chest or where there's lots of lung, it's going to come down and it's going to use less MA. And so tube current modulation, when you pick the noise index value or the standard deviation for a GE and Canon, it moves up and down that curve. Now, if you have a different protocol that needs to be less noisy or higher noise, then you pick a different noise index and it picks a different curve. The way GE and Canon work is the higher the number, the more noise the system will allow. And that's what you can see here. This system at an NI of 20 or an SD, close to 20, it doesn't ever use as much MA. Even for the largest patient, in this phantom, it doesn't use a real high MA. Therefore, the image is going to be noisier. You can also see that these curves are a lot more for the lower NI values that require less noise in the image. Those curves move more aggressively. And so small changes in patient thickness will change the radiation output faster. So you just have to ask yourself that question. Can this imaging task that we're doing, can we do it with lots of or more noise than not? Therefore, we pick a higher NI or a higher SD. And are we as concerned that this patient could swing from really thick to really thin, and therefore the dose could be very, very extreme? So the other thing to consider, Siemens, they do it slightly different, where they actually will select a different curve that will tell the system how much MA to use, once again, based on how thick the patient is. And they call it the weak, average, or strong curves. You can see that they all converge to the same output value as the patient gets thicker. So for very, very big patients, our obese patients, it really doesn't matter which curve you use in Siemens. The output is still the same. But when you get down here to like the little kids, mostly pediatrics, then if you want to be more aggressive in how quickly it changes radiation dose, you would pick a strong curve. So it'll start low, but it could end up really high faster. Whereas a weak curve, it will start maybe a little higher, but as the patient goes from maybe thin to thicker, it actually doesn't change as much in the output. And then Philips is kind of the same way, where you pick a quality reference dose image or image quality based on a reference patient thickness, and then the system will pick the MA trying to match that same noise. So if we say for this size, roughly this size patient, we want a specific noise value, well, the system knows it needs about 200 MA. So if the patient is much bigger, it knows it needs to basically double the dose. If it's much smaller, then it knows it has to lower the dose. So it's kind of the same concept. It's much simpler. Philips is probably the simplest one of them all. All right, so that's how it works. What does that mean in the end product? What does noise look like in the end product? So let's once again look at GE and Canon. For GE, for the most part, so now we have noise on the y-axis, measured standard deviation. This is the amount of, if you have a reconstructed image, let's say of the liver, and I put an ROI in the middle of that liver, not on vasculature, but just kind of in the parenchyma, what is the standard deviation of that ROI? That's how much noise or variability is in the image. That's our y-axis now. Same x-axis, which is patient thickness. So if I pick, once again, a noise index of 10 or a standard deviation of 10, for GE, it's mostly the same. It's mostly flat. It does change a little bit. In other words, GE is doing its best to keep the noise constant as you go from thin to thick anatomy. It's trying to keep it mostly the same. It does vary a little bit. Obviously, as you get higher and higher in dose, it's hard, and thicker in patient, it's not as easy to keep the exact same noise. But for the most part, it does a pretty good job. All the other vendors, Canon, Siemens, and Philips, they fundamentally do it a little differently. When you pick, for example, an SD of 10 on Canon, and the patient gets thicker, so it's going from maybe chest to the abdomen to the pelvis, it actually allows more noise in the thicker, the larger parts of the body than the thinner. And that's consistent across all of the SD values, maybe except for the really, really little ones. And the point here is as you get bigger, it's assuming that there's going to be more, for example, fat in your body, or there's just going to be more space between all of the tissue. And if there is, for example, interstitial fat, or there's fat padding around your organs, then you will be able to easily see this is liver, that's spleen, this is kidney. It's all kind of easy to see. And therefore, if it's a little bit more noisy, you haven't changed your ability to see contrast. And you see the same thing with Siemens. As you get bigger, the patient gets bigger, irrespective of the strength of curve, strong, average, weak, the noise always goes up. And then the same thing with Philips. So I think it's very important to understand these basic fundamentals. So when you go and set a certain NI value or a SD value, and you measure the output, the noise, and you go, oh, hey, I was expecting a 12. Well, the reality is you don't actually get a 12 anywhere but at the thinnest patients. It might actually go as high as, 18 or 19, even though the SD value is predicting a noise index of 12. You just need to understand kind of how and where it's affected in the overall image quality. So when you set your optimization technique, you know how to set it right. Okay. Now, we talked about organ dose modulation last week. So I went over to my scanner. I threw my my volunteer on, my little Phantom, and I imaged it when I turned on, and this is a Canon, so I turned on the organ dose modulation here, and then I scanned the guy again and turned off my organ dose modulation. And here you can see the MA curve. So this is my Z-axis tube current modulation based off of this localizer. You can see obviously the MA is going to go up real high here. And that is because we got these beautiful shoulders right here. And you can see that this is much higher. Therefore, the MA is much more extreme or more strong through this region than it is here. And that's because what you don't see is I turned this organ dose modulation on. So it's doing its best to reduce the overall MA in this region because of what would presumably be breast tissue. And the same could be true for obviously thyroid and the eyes, which we talked about for the head last week. So what does that look like? GE provided this. I thought it was just a good way to graphically see this or pictorially see this. So here's a transactional view of a chest of the thorax. And for the most part, the dose is much lower here anterior. So the breast tissue is definitely getting less radiation, but basically so is everything else anterior to the center of the body. And then on the bottom side, dose is just the same. It's always what it was, and nothing changes. And there was a great question last week about, well, could we use this organ dose modulation in, say, a pediatric patient? And the answer is definitely. I'll share my caveat to that in the next slice. But here you can see if I use the same angle, so I turn it on, instead of imaging here in the chest, I'm imaging down here in the abdomen. You can see the same angle. This area would reduce the dose by somewhere 30 to 40%. And so in this case, most of the fetus would probably be spared some amount of radiation. Now that's assuming the fetus is nice and centered, and that's also assuming that the patient is centered in the image, in the scanner. Do not be tempted to move the the patient. Don't move the pregnant woman higher into the scanner so that more of the fetus would be spared radiation dose due to organ dose modulation. Because remember, when you move the mother up, the system's going to think she's bigger, so therefore it's going to compensate by putting more MA or more radiation out. So even though you moved it up so you get more of the baby, the fetus, into this area that is quote unquote lower dose, you've actually just told the system to turn out the dose. So it's actually potentially you're increasing the dose to the patient, to the fetus, and definitely to the mother. So organ dose modulation also requires you to get that patient, in this case, the mother, nice and centered. Now, I mentioned that GE and Canon, when they use organ dose modulation, they simply turn it down as it sweeps anteriorly, and then they just turn it back to normal posterior. So I think it's a perfectly good and legitimate reason to use organ dose modulation in a pregnant woman. But my only thing I said was you have to be careful. And I'm not trying to be disparaging towards Siemens, but the way they approach it is different. Their version is called XCare. here you can see on the left, there was a study. Here's the publication if you want to read it, where they used Monte Carlo. So they looked at the radiation dose per voxel in this mother, and excuse me, not mother, but this woman. And you can see the relatively even distribution. High doses are white, medium doses are yellow, low doses are red. And so the superficial tissue is here in yellow, and that's getting relatively dose. And as the dose gets, as you get more centered to the body, the dose goes down. That's just because of attenuation. Now, if you turn X-Care on, the anterior aspect of the patient is getting less radiation. But when it spins over, the X-ray tube goes to the back of the patient, posteriorly, the dose goes up. That's just part of the way they do it. Their goal is to put the same amount of dose at the center of the body. Now, my only issue with that is, look at this breast tissue right here. Part of this breast actually got more dose than this breast that got lower dose. So, okay, did we probably over the net value reduce the overall dose of the breast? Yeah, most likely. There's more breast tissue here that got less dose, but this part of the tissue got higher dose, and I don't think that's necessarily a good thing. And then that's just assuming this breast could be even more pendant and more of it could be outside of the field of view. And so this is why I say it's a caveat to using this organ dose modulation option in a pregnant woman, because you just don't know where that fetus is until you scan it. And so this case, for example, there is the potential that this part of the body right here and this part of the body right here would actually get more radiation. And so there is a small potential that even though you're reducing the dose up here, down here, you're actually increasing it. So you just have to be a little bit more careful where you use that technology. All right, so this is that one slide I was talking about doing slice thicknesses. My apologies. It was supposed to be right here. So we talked about how you have to know kind of how thick you want the slice so that you can set your proper noise index value at the beginning. I'm just giving you guys a very simple equation here. It's applicable for both GE, their noise index, and Canon, their SD value. So if you ever want, if you ever want to know what the dose would do if you're changing noise index, then if you use this simple equation, I give you an example here. So let's say we're going to go from a noise index of 10 and I want to increase it to 15. My current CTDI my volume CTDI value is 5. Well, if I change it from 10 to 15, therefore it's going to allow more noise in the image, and I will basically get a dose reduction. And so my dose will basically be halved. Now, conversely, if you go from 10 and you drop it to a 5, well, obviously the number is going to go higher. So you can kind of use this equation. It'll give you, as I say, a rule of thumb. It'll get you really close to guessing what you need if you want to just start playing with, it's like, hey, I can accept a little bit more noise in this image, so I'll increase my noise index. What kind of dose reduction will I get? You can do these calculations without actually making any changes. So what happens if you're also thinking about changing? Now I want to go from a 5 millimeter image to a 3 millimeter image. And so my noise index is 10, but now I'm going to change my value from 5 millimeters to 3 millimeters. So it's a thinner image. My new noise index equivalent would be 13. Therefore, the noise will increase by about 30%, or 13 divided by 10. And so from going from a thicker to a thinner image, the overall image quality will change. So this just is a way to kind of give you a sense if you're changing overall thicknesses. I simply give you these equations as just kind of a tool to play with. All right. So in just the last few slides, let's talk about how we talked, Tanya asked the question, can deep learning and iterative reconstruction too, but deep learning, how does that affect our dose? So the first thing you could do if you get deep learning on your CT scanners, and I hope someday you do get them, And I hope you like them. I mean, just you've only seen a couple of my images. So hopefully you get it, you get to play with it, and you get to decide if you like it. But if you do like it and you do turn it on, the first thing you can do is just simply turn it on. And what happens? Overnight, your image quality goes from what you see on the left to the image quality you see on the right. Now, it'll obviously vary, depends on what your image quality baseline looks like. So the most fundamental thing you can do is you're not going to change radiation dose output to the patient. And the reason I would even bring this up is this image quality right here is probably kind of borderline low. We have historically, Tanya's a pediatric radiologist, and we got Panrutai, we got all these other pediatric radiologists that we have said radiation to kids is bad, so you poor radiologists have to look at really noisy images. That's what we said about 20 years ago. So our poor pediatric radiologists have gotten used to looking at really noisy images. Now, would they prefer to look at less noisy radio images? Probably. And so do we absolutely need to go and immediately turn down the dose? Probably not. I think we're at a point in most of our institutions where we've brought the dose decently low. We've seen your guys' dose, your diagnostic reference levels, as a country, your values are actually middle to low, which means you guys are probably doing really good. And so turning this on improves the image quality. So the images that may be a little extra noisy because you have reduced your dose, well, we're going to get rid of that noise for you and hopefully make it a little better for you. But like Tanya said, what if we do want to keep moving that dose needle down? Yes, we have a lot of flexibility now. So here I took in this patient, I actually didn't change the dose. This is just pure computer calculations. What if I take this patient that is currently getting imaged at, it's got a 3 millimeter thick image. It's got a CTDI value that creates an image quality that looks like this. And let's just say our radiologists, they've been looking at these noisy images so long that they're okay with it. Okay, that's fine. I'm going to do my best to match that noise output. But by doing so, I can use ACE to fix that so I can reduce my dose, and then I can use ACE to clean up that extra noise. And so we've calculated out to be somewhere in the 40 to 50% range of dose reduction potential by simply turning on deep learning and then matching your current noise values to what you're using now. Now, that means for like a GE or a Canon, you would go into your noise index or your SD value and you would actually increase it. But then you would turn deep learning on and it would decrease your noise. So there would be a change. You would have to make a change in your protocols. And then one day Siemens will eventually come out with this technology probably, and you'll have to do it slightly different for them. So where have we gone? And this is kind of just a fun slide I like to show. Let's look at this 10 years ago. 10 years ago, when basically everyone was filter back projection, everyone, pre-iterative reconstruction. Look how far we've come in about 10 years. We are to the point now where if we use deep learning for dose reduction purposes, we could probably be imaging 70 to maybe even 90% of what we used to 10 years ago. That means we're using only about 10 to 30% of the radiation we did 10 years ago. And so that's why I say, by way of dose, we have come down quite a bit. Can we always go lower? Definitely. And would that help us in peace of mind and risk analysis? Definitely. But I would also say we're at that point where we've come down so low. Let's focus a little bit on image quality. Let's just ask ourselves, can we make it that much better for our radiologists? And then maybe get a little bit of dose reduction with that. So I've been mentioning this whole time how you guys are just, in Thailand, you guys are doing great. When you look at your overall national DRLs compared to what you see, rolling around, Japan and Korea, Malaysia, so your local, regional, and then compare that to, America and the UK and whatnot, Australia. You guys are kind of right in the middle, maybe just a little lower than the total global average. And so that's a great thing. That gives you the chance to really focus in on your body CT imaging, on maybe focusing a little bit more on image quality. And so we've talked quite a bit about how we apply the DRLs. And so I'm not going to really belabor this point, but I think it's important to remember, because this is a diagnostic reference level talk or session, the whole several months we're doing this, is once you have these DRLs now, as Dr. Panrutai and her team start to disseminate that information out to all of Thailand, you'll have the opportunity to look at your local institutional CTs. And then you'll be able to compare them to this threshold. This threshold is the new Thai DRL. And you can look at how you compare at your specific hospital, your institution, and then you can start to focus in on this little top part, as there's going to probably be some protocols on most of your scanners that are above the DRL. And then you can work on those. And the vast majority of optimization then for the green stuff will come later when you look at maybe image quality and maybe dose reduction. And the way you approach that is, once you are looking at each of your scanners, it's another thing to do is, how do your scanners compare to each other? So if I take a routine chest, or you could even do, like was brought up earlier, if you're doing a surveillance chest, where you're looking at really low dose chest for, cancer screening. How is that one protocol being performed on every one of your CT scanners? And so doing kind of like a little pie chart like this, you can see in this example, their CT scanner, their CT1, whatever that's labeled, for the same protocol as all the others, is actually much higher. It's almost 50% higher than all three of them put together. And so where should this optimization team put their focus? Well, obviously on CT1, and then maybe next CT2. And so the point here is as you start to look at all your local data and you start to look at it per protocol, then you'll start to realize, oh, I could make a big difference if I focus on one scanner. Now you can see here on this one protocol, CT1 it's grossly out of proportion compared to the other three CTs. But when you look at the total magnitude of that CT scanner, it's actually very low by way of total number of examinations compared to CT3. So most people would probably, their immediate reaction would be, oh, I use CT3 all the time. Therefore, if I go work on CT3, I'm going to make a bigger effect for more patients. But the reality is this CT scanner is actually causing most of the radiation dose to the people that get imaged at this hospital. All right, so how do we use this patient data to make educated decisions on how we change our protocols? So there's two ways to do this. Obviously, we have all this data. You guys are going to eventually get Radiometrics installed throughout Thailand, and that'll be a great way to get the data back to the national organizations, so Dr. Panrutai's group can create more DRLs and continue to update the DRLs going forward. But locally, as a tool, we talked quite a bit about this in the first couple of weeks, but using that dose repository software gives you an idea of how well you as an institution are doing, for example, chest without contrast or abdomen pelvis with contrast. You can look at the scatter profile as a function of the patient size, or if you don't have that, patient age. And then you can fit this data, and I have on the next slide, I have some equations, and you can use those equations to predict how the dose and noise would change if you make different adjustments. The other thing you can do, and this is a Phantom that I actually own. It's a big old honking Phantom. It's probably about this big, and it probably weighs about, I don't know, probably 60, 70 pounds. So it's something you could take with you to go to the gym if you really want to. But it's great because it has different thicknesses. And so this one phantom can mimic all of the various different patient sizes that would ever walk into your hospital. And so when I go scan this one phantom, depending on whatever protocol I want to optimize, I can determine what technique factors I need to change for each one of these patient sizes. The red line you see here is, according to this publication that just came out actually last year, they looked at this phantom and they asked, does this phantom mimic actual patient data? And that red line represents yes. So in other words, I have confidence that I can scan this phantom and I can go in and then start adjusting things, image quality, dose, and all that stuff. And I know that if I do it first, let's say this middle slice, it's going to represent my patients that are, 30 to 35 centimeters thick. And so that's a great thing. So you guys could, if you wanted to, invest in maybe one of these phantoms and maybe a couple of them regionally, and your medical physicist can take them around. Or, like I said, you have your data. Once you get your software, you can do these scatter plots, and you can use these fits to your data, and you can use these equations. So these equations are pretty straightforward, where you can predict what the radiation dose output would be, or sigma, which would be standard deviation. I should have wrote here noise. This is the noise calculation. Based on the fitting function of this red line, which would tell you what alpha, A1, B1 are, in this case, beta, C1, and D1, then you can, based on the patient effective diameter or the patient size, you can predict what the CTDI vol value is and noise. So you can either use this phantom because you know which thickness the phantom is, or you can go back to your data and you can know once you fit your data, you can know what the size is. So if you're using, for example, that phantom, I just simply give you this plot, this table, as you see here on my screen, comes from this publication. And so here you can see the A1, B1, alpha, C1, D1, beta. So if you go plug these values in, if you're doing, for example, a chest without or an abdomen pelvis with contrast, and you can use these equations. They're generic values. You can see they established it for a couple of their scanners, but you can see how the numbers are, for the most part, the same. If you wanted, you could just kind of average them together. But the idea here is you can go back to your data. You can fit them using this equation. Fit them with an equation. And once you get those fitting functions, alpha, A1, and B1, then now you have these two calculation tools to just do whatever you want to make any kind of predictions. And what I'm saying here is you can make these predictions before you actually go in and start making changes on the protocols. And it kind of gives you a better idea that make sure you're doing the right thing before you start exposing your patients. All right, so in conclusion, use the right size bow tie filter. That's the same as we talked about last time too. Make sure your patient is centered because that directly affects the radiation output to the patient. Use the proper acquisition factors. Wherein possible, use the lowest kV. Obviously, really big patients can't use low kV, but wherein possible, use the lowest kV. It enhances image contrast and it lowers patient dose. Always use tube current modulation. I would say use organ dose modulation too. You're out nothing. It reduces the dose to the more anterior and oftentimes more sensitive organs. And there are those little niche ways that you can maybe potentially do it with, say, pregnant women. If you need to image a pregnant woman, and you have to do an abdomen image, so you know you're going to be directly exposing the fetus, then this is one of those things where maybe it's a great tool to have. And then how do you set the right noise index value, NISD, the quality reference dose, quality reference mass, and then how do those affect dose? We reviewed that. I've given you now several different equations in this presentation so that you can use those to kind of do your calculations before you make changes. And then how do you set that for the proper slice thickness, clinical diagnostic tasks, etc. All right, so I think we can turn it over for questions now.
Thank you so much, Sam, for your excellent talk and simplify things. So you made me feel like, yeah, it's not that bad to learn some physics because it's fun. At least I know some background and it's not that bad to understanding. So thank you so much for your excellent lectures.
Well, I'm glad you liked physics so much.
Hey, I think I feel a lot better about the physics thing behind the scene that in the past, I did not even know why it happened that way or what is it. Just like I remember the number for the test.
Yeah, that's true.
I have a couple questions. So, I mean, based on your 2 lectures, if we want to write some manual for the technologists or for the radiologists to understand the basic principle for optimization, can I say the first thing is that put the patient in the center of the gantry, and second thing is like you need to know the final product, final images for you to review, like a bone window, soft tissue window, or which one is like the most important to you. So by that way, you can choose the correct filter or kernel to do the process to process the image.
So the answer is yes. And always the best principle, the best way you can reduce the dose of the patient is taking the time to do the right thing. And your technologists I know they're amazing, just like our technologists are amazing. They're trained to put the patient in the right place. They're trained to help them, to calm them down so they're not moving. They're not breathing hard. They're, keep their heart rate low. So they're talking to them. They're being nice to them. All of those things, they may seem like, oh, that doesn't affect dose, right? That doesn't affect image quality, but actually it does. And so our technologists are usually the first people to help affect radiation dose and image quality. And so doing the right thing, taking the time to do the right thing, getting the patient centered, etc., keep them warm, do whatever it is that you have to, that is wonderful. And then the protocols that we build as a optimization team, radiologist, physicist, technologist, IT specialist, their task is to look at all of those things we've talked about from the very, very beginning, that long list of all of the settings, and ask ourselves, for this clinical indication, for this protocol, what do we need to optimize? And so, yes, which bone window, which noise index setting, all of those things are going to be set beforehand. And I believe very strongly that should be set and then put into the computer and programmed into the CT scanner. And that's probably how it is for you guys right now. So when the technologist gets the order, they get the patient in, they get them set up, they go sit down at the console, they pull them off the work list, and then they go, okay, based on either patient size or weight or however it is you guys have set up your protocols, they know to pick whatever protocol it is, because it's either a chest, abdomen, or pelvis. And then it comes up, they do the localizer, they set it, they get the field of views nice and right, so it's not too open. So they set the right field of views. That obviously improves image quality. And then they scan them. And then all of the post-processing things happen. Iterative reconstruction is already established. Slice thickness is already established. If you have deep learning, or one day you will, that will also process in the background. You'll have usually 1 reconstruction kernel, maybe 2, maybe 3, because those are usually built up as secondary processing. And all of that just happens. And so then the patient can get off the table and can walk out the door. The technologist can finish their paperwork and move on. And all of that then goes off to the radiologist to review. It's just really important that we look at it holistically so that we can get all of that in the right order. And then that really just, so, at some point you're going to have to kind of go through your protocols one by one. Let's focus on chest. Do we like that they're all 5 millimeters? Should we have one set of 5s and one set of 0.5s? Do we like the overall image quality? Is there too much noise for what we're doing? Should we lower our KV? And so you just kind of go through those questions as you go kind of body part to body part, task to task. And then that's the way I found, as I've done this for the last few years. That's the best way I found to go through it. If you look at all your protocols at once, you'll be overwhelmed. You will. And so just pick those ones. You have the national diagnostic reference levels. So you know which protocols are kind of upper on the high dose level, especially the ones that are above the national DRL. And we're going to focus on those. And we're going to go through that list of all the things that you mentioned.
So you talk about like the finals protocol that we want, like a soft tissue, mainly like for soft tissue window or bone window. How much difference in terms of radiation dose if we choose between like a soft tissue or bone window? Because sometimes, let's say some study, we need both of them.
So
but in
yeah, so the reality is almost always you will set your dose to the soft tissue. And that's just going to be based on the fact that maybe you'll do a 5 millimeter, you'll do a relatively thicker image for soft tissue because you need to average it so you get less dose in it. Less noise. And you're going to set your kernels, you're going to set your noise index values or the noise parameters that affect the output of the machine. And then you'll add whatever kernels you want to it, bone, lung, whatever. And then bone, for example, you might want a thinner slice so you get better resolution in the Z-axis. Will the images look maybe a little noisier? Maybe. A 5 millimeter soft tissue and a 5 millimeter bone image, the bone image is probably going to look pretty good. But at 5 millimeters, you're getting a lot of averaging. And so, if you cut those thinner, now you're going to be able to see a little bit more finely the detail in the Z-axis. But because they're thinner, they're actually going to have a little bit more noise. And so it actually kind of works out a little bit because the dose is set a little higher for the soft tissue versus the noise. For the bone. And so I would always default to the soft tissue.
So default to the soft tissue and also thickness, maybe 3 millimeter thickness.
That really has a lot to do with preference. There are certain clinical indications where a thick image is actually helpful. We talked about that in the brain. But in the body, because for the most part, when you're certain slabs of the brain, you can kind of go a certain distance, 3 to 5 millimeters, and the anatomy doesn't change that much. But in the body, the lungs, you could maybe go thicker or thinner, but it just, for the most part, our anatomy changes so much in our body that we really do need to have thinner slices. 5 millimeters, probably the maximum you'll ever do in the body. 3 millimeter, if you got a smaller patient. Our little kids, we do everything consistently at 3 millimeters. But oftentimes we will do like a 5 millimeter, and then we'll also let the radiologist look at the 0.5 millimeters. Now the 0.5 millimeter images are really grainy, really noisy images compared to the 5 millimeters. But if they're going through and they're looking at their 5s and they're just like, there's something in between these two images I want to see, they need to see something thinner. And so we have those for them to look at. And now if they look at it and go, oh, this is too noisy, they can always call the technologist and have them make 1 millimeters. They can add them or, start adding them together. Where you're really busy, I know Thailand, when I was there in Bangkok and we were there, those scanners were going 100 miles an hour. There were lots of patients. And so the reading room was very busy. So there's probably not a lot of room to make for the radiologist to call the technologist and say, hey, I need you to do this and this and this and this. And so you do, as an optimization team, need to kind of think about how the workflow is. And so you kind of want to give the information to the radiologist that they need so they don't have to make any phone calls.
True. อาจารย์ปานจะถามอะไรก่อนไหมคะก่อนที่จะเข้าถึงคำถามของ
มีคนถามมาเยอะเลยให้เขาตอบ
Oh, you are so popular, Sam. We have a lot of questions on the chat box.
All right, let's see here.
Yeah. First questions from Thai Pat.
Oh, yep. And then someone asked about Hitachi. So the reason I haven't really, admittedly, I did include the GE, Canon, Siemens, Philips. Those are the kind of the big four. Most places will have one of those four. Now, I know some people have a Hitachi, especially over in Asia. There's probably a little bit more Hitachi. I'll try to see if I can't find more information on Hitachi in the future. But admittedly, when you look at the publications, there's actually not a lot of data on Hitachi. But I will do my best to see if I can't include that in the next lesson lecture.
I think that is the audience from Bhutan. that he joining the lectures.
Yeah. Yeah. So I have nothing against Hitachi. It just admittedly, there's not a lot of Hitachi that is used in publications. All right. Yeah. But Hatapai,
if
she
we
says,
use the low KV or auto KV selection, incorporate with the tube current modulation, aiming to reduce the patient dose and improve the signal contrast noise ratio in the image. What should be concerned or aware in different vendor, because sometimes the higher dose is observed when using the low KV in some patient.
Yeah. So, and that the answer is, when you do the auto KV, you do have to set your ranges, because it's like as she mentioned, that there are times when the system, because it's trying to optimize the CNR, the contrast, it will allow the system to go too low on the KV. And so if you have a big patient, it might still try to use, for example, 80 kV, where it really shouldn't go lower than maybe 100 kV or 90 kV. In which case the dose, the image quality does not look real good. There are other times where then if the KV goes really low, if it's a big patient and you allow it to go to say 80 kV, well, the MA is going to go really, really high. And in that case, even though KV does change as the square root, excuse me, not the square root, the square, it's a quadratic. If the MA goes really, really high, it might actually cause the dose to go too high. So setting limits to your auto KV system allows the system to act intelligently. In other words, you can't just walk in, turn on auto KV, and just sit back. The system can at times go too far to the extremes. You have to give it its limits. Just make sure I got.
Yeah, and the following questions on that things. For the upcoming BL reconstruction, is there strategies taking into account for contrast noise ratio in algorithm?
The answer is no. Currently, no. There is, so when Canon developed their deep learning algorithm, they did their best to reduce noise and improve spatial resolution just a little. And the same with GE. If you go from their low to medium to deep learning to selection, you reduce a lot of noise. If you go from the medium to the high, it tries to also sharpen the edges a little. But the reality is that's all the deep learning is doing, is mostly just removing noise. And so you have to still make sure you've got the right KV set so that the overall contrast is the same. Now, will contrast to noise ratio go up? Yes. If you remove noise, contrast to noise ratio, obviously noise is in the denominator, the contrast to noise ratio will go higher. But they're not necessarily trying to drive that higher. They're just simply trying to remove the noise. So if you have the wrong KV set, then the contrast, the overall contrast in the image would not be good, but it would just be less noisy, if that makes sense.
Next question is from Hong from Singapore. So during patient's positioning at the start of the examination, is the X-ray tube at the upper part of the gantry 12 o'clock or at the bottom of the gantry at 6 o'clock?
Okay, so that's a great question. So when you walk into the room and you place that patient on the scanner, that X-ray tube, who knows where it is? It could be here, it could be here, it could be here, it could be here. When you turn on the lasers, the laser localizers, the tube will move to an exact position so that lasers could come out. Mm-hmm. And it's, if I remember right, it's like, I think it's at 130 degrees. So 0, 80, 180. So 130 degrees is somewhere like right around here. But that's only so that the lasers can come out. Now you put the patient on the scanner and you go in and you do the anterior posterior the AP localizer where the patient goes through and the tube is static. And now you go back and then it swings over to lateral and then the patients go through. So now you have your two localizer images, your quote unquote scouts. And you've set your parameters, you've set where your field of view is, your scan field of view, and then you hit go or next, the machine starts to rev up. Now, when you go to turn on and scan the patient through the machine, the x-ray tube will start at a random place every time. It doesn't only start exactly at 0. It could start here, it could start here, it could start here, it could start over here. And so we never know exactly where it will start. It's perfectly random. But we know exactly where it is when we do our localizers, and we know where exactly it is when we have the laser light on. Those are the only 3 places we know where the x-ray tube is.
I see.
Excuse me, because in the many recommendations, they said that we should put the tube at the bottom at 6 o'clock in the beginning, so that the anterior sensitive organ will get less radiation dose.
Yep.
During the scout. And,
yeah.
And
Go ahead.
I think in the first image about the patient isocenter, the tube is posterior. So the position of a patient up or down and the size display on the scout depend on the position of the tube also.
Yeah, and thank you. I should have pointed that out. When I said the patient is wherever they are, it's always referenced to where the tube is. So if the tube is posterior, so below the table, if the patient is actually too low, then they're closer to the tube. And so in that case, the patient would be magnified. So in that one slide, if you always consider, let me see if I can go back real quick. Nope, sorry. Wrong one. There we go. All right, you should be able to see my screen now. So the patient is always with respect to the tube. And so yeah, depending on where you start, if your tube in this case is below the table, and the patient is lower, then they would still be magnified. So yes, thank you, Panutai, for pointing that out.
ท่านปานลองอธิบายเป็นภาษาไทยอีกรอบได้ไหมคะ
คือว่า
language
มันจะมีอยู่ที่เครื่องเลยตอนที่เทคเขาตัด CT เครื่องมันจะบอกว่าหลอดเนี่ยอยู่ข้างบนหรืออยู่ข้างล่างแล้วให้เราเปลี่ยนได้ปกติเขาจะเซตมาให้อยู่ทางด้านบนคราวนี้มันก็จะมีคนที่เขาแนะนำเขาบอกว่าให้หลอดไปอยู่ด้านล่างซะพอมันปล่อยแสงตรงสเกาต์ออกมามันจะโดนทางด้านหลังซึ่งเป็นกล้ามเนื้อเป็นกระดูกก่อนมันก็จะมาผ่านถึงไทรอยด์เบรสหรือว่าไอเลนส์เนี่ยได้น้อยกว่าหรือรังไข่ก็ตามเพราะมันต้องผ่านส่วนข้างหลังนะคะพอเสร็จแล้วเนี่ยพอการที่มาอยู่ตรงนี้พอหลอดมันมาอยู่ข้างล่างปุ๊บมันก็จะกลับกันคือถ้าคนไข้อยู่ล่างภาพมันก็จะใหญ่ถ้าเกิดภาพใหญ่บอกขนาดของคนไข้ว่าโตกว่าความเป็นจริงถ้าเกิดว่า AEC มันถูกเซตโดยการที่ดูจากไซส์ของคนไข้ด้วยมันก็จะกลายเป็น overdose ตรงนั้นได้ถ้าคิดว่าคอนเซปต์เป็นอย่างนั้นนะคะแต่ว่าพี่ไม่ค่อยแน่ใจจริงๆว่า AEC เนี่ยเขาเซตจากสเกาต์แน่ๆแต่ส่วนหนึ่งอาจจะเป็นไซส์แล้วก็อีกส่วนหนึ่งอาจจะเป็น density แล้วก็มีเครื่องของบางยี่ห้อเนี่ย AEC มันจะเปลี่ยนเวลาที่อะไรล่ะกำลังสแกนด้วยแล้วมันก็จะเพิ่ม information เข้าไปเพราะฉะนั้นแต่ละเครื่องมันทำงานไม่เหมือนกันคนละยี่ห้อมันจะทำงานไม่เหมือนกันด้วยบางยี่ห้อเขาบอกว่าต้องเป็นสเกาต์ AP ด้วยสเกาต์ PA ไม่ได้บางยี่ห้อบอกว่าต้องสเกาต์ lateral ด้วยอะไรอย่างเงี้ย
AEC มันคือไอตัว Q moderating
ค่ะ
ถูกไหมคะ
ค่ะ
อาจารย์ถาม ถามได้ที่อาจารย์ไม่แน่ใจอาจารย์ถาม ถามคุณแซม
Sam, about the tube current modulation among different vendors, they have the different way. Like some say they use the two scout view, and some say they have to do the frontal from the top, not from the bottom, and some say they use the last scout to use in the AEC. And some vendor, they said they use the information during the scan for the next scan, and some don't. So they're quite complex, and
Yes. For the most part, in the past, it really mattered if you did one or two scouts. The last one was the most important one. Because back in the day, it depended on, that was the one they used the tube current modulation. That's not as true anymore. Nowadays, they use, if you do two, they're going to try to use both information, the actual attenuation profiles from both of them. So don't worry too much about what order. I actually personally prefer to do, when you do the lateral first, then you can see if the patient is centered. And then if you know the patient is centered, I mean, let's say they're not, let's say they're really bad. Well, then you go fix it, you move the table, and then you do another lateral scan. And then if they're good, then you switch it over and you do the posterior anterior or the AP one, either way. And then now you've done maybe 3 scans, but that's okay. If you do the AP first, you don't know if they're centered. And then you do the lateral, oh, they're not centered. Well, you have to do it all again. And so it's just, that's why I personally prefer to do a lateral first and then the anterior posterior. Now, Siemens, you mentioned this. Siemens is one of the few scanners out there that you do the scout images, or in their case, the topograms, and then that will pick the tube current modulation. Now, once you have the tube current modulation, as it is scanning, what happens is every time it goes 180 degrees, it takes how much attenuation it passed through, and it uses it to modify the next set of MA for the next 180 degrees. So, excuse me, even though it's already calculated what it thinks, it will slightly modify that in real time. It's actually a great technique. So do you still need to do your topograms or your scouts? Yes. And does it matter which order? If the vendor says to do it in a specific order, yeah, you should do it that way. But for the most part, more modern CT scanners, it doesn't matter that much anymore because they use them both.
I see. One more questions from the chat box from อาจารย์เพชรชลีอาจารย์จะถามเองไหมคะ
Yeah, let's see. Yep. So to conclude, my understanding in case of the same patient with same CT scanner and the same CTDI vol value, but different scanning situation, we may have different noise levels. So if it's the exact same patient with the exact same output and they're in the exact same location, the noise should still be the same. If they mean by different scanning situations, like different clinical indications or different clinical protocols or reasons why they're scanning, then they can definitely change the CTDI value, or they can change the noise value to make it lower or higher. If you're doing an inherently high contrast image, such as calcium scores, or you're doing you're doing a lung image where you're looking for METs, then there's a lot of already contrast there, so you can reduce the dose. I hope that's what they were asking. And then the other question they had was, how do we find the image quality techniques. So I'm going to actually flip over. I pulled up an image on my other screen. Okay, so now you should see my desktop. So here is just one image. Yeah, so you see my chest image right there. So if you look at the DICOM information.
We don't see it yet.
Oh, you don't see anything?
Yes, we saw your screen.
Okay, so you see the image over here and you see a bunch of words over here?
Yes.
Okay, perfect. So this is the DICOM information from this particular CT scan. It's going to have all your basic stuff information, you know, the vendor, the type of imaging it's doing. It's going to tell you down here basic information such as, you know, which way it's spinning, how fast it's spinning, the output, you know, what's the MA for this slice or this image right here. It's going to tell you, you know, the focal spot size. It's going to tell you the reconstruction kernel. And then it's going to have a bunch of numbers here that really, so like, for example, that I know is my pitch because I set it up. That's my total collimation. And so it gives me the information about how this was acquired. The question was, does it tell you about the image quality? And so the one thing that it doesn't show you is the noise index value or the SD value, or if it's a Siemens value, the quality reference mass. That stuff is almost always hidden down here. Oh, my system doesn't even have it. There are, yep. So normally your PAC system may have, so at the bottom of the DICOM list, there'll be things called private tags. And unfortunately, mine just doesn't have it. And in those private tags, it will list it, but it won't tell you what it is. So if you have a GE or a Canon or a Hitachi or whoever you have, you may need to just reach out to that vendor and say, your noise index value, what is your private tag number? Is it, you know, 7005, 100F? And if it is, then you can go and you can find it. But up here, where they list all of the other really important information, unfortunately, they do not list the noise index value. So they give you all the other information that help you understand what the image quality is, such as MA and KV and slice thickness and all these other things. But it's that one piece of information they don't quite show. And so it's unfortunate. But it is there. It's hidden, but it's there. And so my recommendation is talk to your CT vendor and ask them which private tag they hide it in, and then you would find it out.
I see. So I guess the noise index, you have like a standard number or like a table for the noise index for each, like a scan or like each organ, right?
For each slice. So, well, okay. So if you have, for example, this patient you see right here, I would have set up an SD of, I don't even know how big this patient. This patient probably had an SD value of 12.5. I'm just guessing based on their size. In other words, every slice would be 12.5. The way GE and Canon set it up, it's the same throughout the entire scan series. Now, if I put my ROI, over here, and I measure my standard deviation, well, that's a bad place. This is a 0.5. Hold on, I got to get a. There we go. I got to get a 3 millimeter image up. So let me put my ROI here, put it over here. Now my standard deviation is almost 8. So I was probably wrong. It's not 12.5. It's probably 10 or something like that. But now you can see how the standard deviation is different. If I come over here, let's go a little deeper into the body. Well, it's a little too far, but whatever. Let's put it in my ROI here. Put that there. Now my standard deviation is 14. So it's the same SD value or noise index value, but the noise itself changes a little bit with the patient thickness. Now you remember, here I can flip this down. You can still see my screen, right?
Uh-huh.
Good. Right here. So remember, noise output isn't flat. I mean, GE tries to do it flat, but even GE is not perfectly flat. So as the patient gets thicker, as they go along, it does change a little bit. So that's why you're seeing over here, as we go into the pelvis compared to the, whoa, all of a sudden really big chest. So when you go from the chest down to the pelvis, oh my goodness. My computer doesn't like to work. It's midnight.
It's 1 a.m. already.
That's why my computer's not working. So when I go from a relatively thin part of the body to a thicker part of the body, the noise profile does change a little bit. So that's one thing to consider.
I see.
All right. I lost my chat. Let's see if there's any more questions.
There is one more question about the bow tie filter. So is the bow tie filter change when we do localization images?
Oh, that's a good question. The answer is no, we do not change it. Which filter do they use? They use the large filter. And that's because when we do a localizer, we're using a full field of view. And so that's why when you see the localizer, the patient, you can see the whole patient, arms, legs, everything. It's the full 50 centimeter field of view. It'd be interesting if I went back and I actually, because on a smaller patient, no, it's always the same. I'm almost 100% certain you can't. You could change it if you want, but it's almost always the same. So you don't have to worry about the bow tie filter when you're doing the localizer. It's automatically set to the largest.
So, but when you say like you change the filter, it's just like a click, right? Like a one click from the screen or something, right?
Yeah, no, it's here is, let me grab my image quality talk. And let's get back up to the bow tie filter right here. So for example, right here this is a Canon. Each vendor will have it in a different place. But if I click on the filter, then I get to choose which one I want. So I could, in theory, change it. But for the localizer, I wouldn't, because it's, like I said, it's a large field of view. You want it to stay big because you want to be able to see the whole image. I don't know if I have a localizer here. Nope, I don't. But yeah, you have the opportunity. It's a simple click. But this is something that you would establish as an optimization team. When you build the protocol, you set which protocol filter, you set the KV, you set the noise index value, you set all of that. And then the technologist doesn't have to worry about that. The technologist has to worry about the patient. Is the patient centered? Is the patient happy? Is the patient responding? They have to worry about the IV injection. They have to worry about all of those kind of things. We don't want them to be worried about picking the right filter. We don't want them to be worried about picking all those types of things, if that makes sense.
I see. That makes sense. Yeah. อาจารย์ปานมีคำถาม มีคอมเมนต์เพิ่มไหมคะ
I would like to ask about the CT neck. You mentioned about the CT spine in the beginning. If we would like to do the CT neck, use the same concept as the C spine, right?
Yes. So if you're doing more like a soft tissue instead of the C spine, the answer is yes. For us, for our soft tissue necks and our C-spine or bony, we start at the shoulders and we go up. And then we had to make sure we set the right minimum MA. Those are our two things we found. Yeah, whatever you do for, you know, the neck in general, I would do the same. Even though it's different clinical indication, it's still the same anatomy. You know what I mean? Yeah. You may need a little less noise. So you may need to set your minimum MA a little higher. Whereas in bony anatomy, that might be okay. Even though it's not perfect, this might be okay right here, what you see on the screen. Whereas soft tissue, this might not be enough, in which case you might need a little bit more radiation.
Yeah, I would like to ask more because there is some requests. It's like neck and chest. And if we like to do it in continuous, and probably the with the hand up.
Mm-hmm. That is a trick. So if your arms are up and you're trying to image the neck, you're going to have a lot of artifacts.
Neck, chest in continuous. Oh, should not do that. Should they split the examination?
The answer is whatever's best for your patient. You know, the way we do it, we split ours.
I think we do split too.
We do our neck with our arms down, and then we put the arms up and we do the chest. And that's just the best way for the image quality. If the patient can't move their arms, or the patient, it's a trauma case and you don't want to move their arms, then you have to, or you don't want to keep moving the arms is what I meant to say. Then you need to pick the most important question to ask. Because if you put your arms by your chest, you're going to get a lot of artifact through the chest, especially down in the spine area. And if that's where the trauma is, then you got to move your arms up. If you need to put the arms up for the neck, the other thing you can do is instead of putting them straight up, you can put them out a little bit. So the arms are above the face. So, but we split ours personally.
Yes. Wow. Thank you.
We have a very, very productive discussion today. And a lot of interesting questions and a lot of homework to you too, to find out the Hitachi.
I will see if I can't find Hitachi. I've used Hitachi MR quite a bit. Hitachi does a lot more MR than CT.
So thank you so much, Sam, for giving a lectures and during midnight for us, at midnight and 1 a.m. So thank you so much. And so for the audience สำหรับท่านผู้ชมนะคะก็จะมีลิงก์ส่งให้ทำประเมินนะคะในเรื่องของ evaluation นะคะรบกวนทำประเมินให้เสร็จภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์จะได้รับใบ certificate แล้วก็คะแนน CME นะคะแล้วก็วันศุกร์จะได้รับลิงก์ของการประชุมในอาทิตย์ถัดไปนะคะมีหลายคำถามถามมาหลังไมค์ว่าดูย้อนหลังได้ไหมหรือว่าอะไรยังไงนะคะสามารถดูย้อนหลังได้นะคะทาง YouTube Imaging Academic Outreach Center นะคะแล้วก็สามารถดูย้อนหลังได้ทาง Facebook เหมือนกันนะคะแต่เท่าที่ตัวเองสังเกตดูแล้วเนี่ยใน YouTube เนี่ยภาพจะชัดกว่าใน Facebook นะคะแล้วก็PDF lecture นะคะจะมีให้สำหรับท่านที่ลงทะเบียนโดยที่ท่านต้องล็อกออนเข้าไปนะคะในอีเมลที่ท่านใช้ลงทะเบียนนะคะแล้วเดี๋ยวทางเจ้าหน้าที่เขาส่งพาสเวิร์ดไปให้แล้วเดี๋ยวให้เขาส่งให้ใหม่อีกทีนึงนะคะว่าจะใช้พาสเวิร์ดอันไหนในการเข้าไปดูนะคะเพื่อได้ดาวน์โหลดเอกสารประกอบการประชุมนะคะ so for the international audience we're gonna send you a link for evaluation. Please complete the evaluation by midnight on Thursday. So on Friday you will get a certification with the CME credit, and also on Friday you will get a link for the next week talk. We also have a PDF lectures put in the website. So you need to log on using your username and password. So the username is your email address when you register to attend the lectures, and password we're gonna send the password to you again, so you can log on and download the PDF lectures. And if you want to review the lectures, you can watch on the YouTube Imaging Academic Outreach Center channel and also on the Facebook Imaging Academic Outreach Center. But YouTube, I think the image quality and the quality of the video on YouTube is a bit better compared to the Facebook. And I also would like to thank our sponsor to support this event, including IAEA. And we also have the sponsor from the vendor, Buyer Thailand. We have Philips, and we also have the sponsor from GE. So thank you for support our this activity to help us establish the national dose level and also optimization to the patient and for the Thai populations. So thank you so much, Sam, for giving the lectures and attend the lecture, answer the questions for us. So I will see you next week. And next week is going to be the last week for the CT. And you are going to talk about the cardiac CTA, right? And also CT fluoroscopy. Right?
Yep, I thought we would talk about some of the specialties. So we might even talk a little about dual energy, but we'll mostly talk about cardiac and a few other things.
So thank you so much and have a good night and have a nice day, everyone. Thank you. สวัสดีค่ะ บ๊ายบาย